Well, good morning, friends who are on site and friends who are online. A warm welcome on this wonderful Sunday morning, the 24th of July, 2022. We are now going to start our opening session today, and I would like to invite somebody who has been a dear friend. We have worked together in the past, we are working together now, and he was my trainer when I trained as an agent advisor in Max New York Life Insurance Company, and I learned a lot from him. Today, I'm so proud to welcome the one and only enter-trainer, motivational speaker, super dad, super husband, super son, super brother, and Superman, Mr. Hariharan Iyer. Give him a big round of applause and we welcome Hari.
Okay, good morning. So there is a bit of a, I did not realize that if I have to do a doctor's session, I need to be a patient. So I'm just going a little treatment for my ears, so please bear with me. In case I don't hear you, if you say something, you'll have to repeat it for me. So that's the only request. Otherwise, I'm fine. And just that going through a little process. Okay, so first of all, yeah, it's getting better now. I think the moment I'm on stage, everything becomes better. Okay, you see, we are narcissistic people, and motivational speakers are like that. So, okay, so first of all, I think it's a great honor, and it's an absolute privilege to get this opportunity to come and stand in front of such an audience and address. I think I got to know about this session about 3 weeks ago, and for the amount of money Nikhil is paying me, it's very less because I had to prepare for 3 weeks for this session because I was wondering what to tell doctors. And for all you know, I'm just one of those guys who walks through your door every day, you know. And you never know, your next patient might be a motivational speaker. So, right? So I'm just a very normal guy who walks through the door of your clinic or your hospital at any given point of time. And to get such an opportunity for a common man like me to talk to all of you is an absolute honor. So thank you so much for this opportunity. And I've been very strictly warned on the timing part, so I'm going to kind of get this rolling now. So I've come up with a very audacious subject, which is what they don't teach you at medical school. Now, in case you already know about it and they taught you at medical school, I'm very sorry because I have no idea what happens inside a medicine school. Because I wanted to be a doctor myself, and just that people did not tell me that you have to pass your 12th standard minimum to become a doctor. So I didn't manage to do that, and so I had to go back to arts. You know, in our days, 1970s and 80s, when we were growing up, we were very clearly told, if you are a smart guy, you do science, and if you are not a smart guy, you do arts. You know, and if you're somewhere in between, you do commerce. I think now the trend has reversed. Smart guys are doing arts, and super smart guys are becoming doctors like you. Yeah? So, and the in-betweens continue to do commerce. So that's great. So that's something that is not changed. So we're going to look at something very interesting. Now, I've divided this little session into 3 parts. One is we're going to do a quick icebreaker, and we're going to have a little fun. Second is what I have learned from all of you, from your profession, is what we're going to talk about. And the last, of course, is some wisdom from management sages, as I call them. So does this look like an interesting plan for the moment? Yeah, thank you so much. Yeah, so are you ready to laugh a little bit at yourself? Okay, so I have already taken your yes. So, you see, doctors give a lot of complicated terminologies to lay people like us. And the only medical terminology a common man in India knows very well is lymphosarcoma of the intestine. Yeah? And we don't know anything more about medical terminology than lymphosarcoma of the intestine, thanks to Amitabh Bachchan, Rajesh Khanna, Rishikesh Mukherjee, and Ramesh Dev. I think you're all part of that particular scene in that historic film Anand, which was released in 1971. Okay, so because you guys give us such amazing terminologies which we can't make any sense of, so I thought let me take a little revenge on all of you. And let's do a little terminology check here. Not medical terminology, something else. Okay, so let's blame it on Shashi Tharoor, because he uses words which are more complicated than the medical language also. So let me test your vocabulary to begin with. Okay? So what is the meaning of floxinoxyhilipilification? Any idea? What is the meaning of you see, I got the pronunciation right. I think so, I don't know. That just goes to show how many times I must have watched that video on YouTube. Yeah? Floxinoxyhilipilification. Sorry? Okay. So you want to know the meaning, exact meaning, and know how to apply it? Okay. It means the action or habit of estimating something as worthless. That's what floxinoxyhilipilification means. Sometimes when you're frustrated with your patients, you can just put this word on them. You can say that, why are you giving me a floxinoxyhilipilification moment? Okay, let's go to the next word now. What's the meaning of defenestrate? Any idea? So if you don't know, just say I don't know. I like your way, sir. You put your hands up. Shoot me.
I know.
You know defenestrate?
Yes, I know.
Okay.
Yeah, paying a doctor's fees.
Paying. No, that might be floxinoxyhilipilification. You might find it worthless to pay so much from a patient's perspective. Okay, defenestrate essentially means to throw or push someone out of the window. So some patients behave really badly or they don't follow your advice. Tell them next time I'm going to defenestrate you. I'm going to throw you out of the clinic. Okay, ready for the next word? Yeah, this gets very interesting now. So what does agathocacological mean? Any idea? Agathocacological. It has no logic. It looks like it does not have logic, but it's a very powerful word. And agathocacological means someone is made up of both good as well as evil. So it's a combination of. So when you look at Romy, he is only good. There is no evil in him. So he does not qualify to be called as an agathocacological person. Okay, here's the last one. Blame it on Shashi Tharoor. What is the meaning of, I love this. Out of the four, I loved this one. What is the meaning of Panglossian? It almost sounds like a medical disease. What is the meaning of Panglossian?
The one who takes panga.
One who takes panga. Yeah, it's a very panga word for sure. Okay? So, a Panglossian is somebody who is excessively optimistic and very stupidly optimistic. So, for example, during the pandemic, we all learned that you should not be positive because then you will be termed as COVID positive. Yeah? So if you said I'm positive, then people run away from you. If you say you're negative, they love you now. That's the new positivity. So there were a lot of pan-Gaussian elements in our country who thought COVID will happen to my neighbor, not to me. You know, they were so optimistic, stupidly so. So that's what pan-Gaussian means. So can we have a round of applause for Shashi Tharoor? Thank you. Okay. Now I'm going to really get serious now. And you can see how serious I am there. So, you know, we had this little laugh right now. We had a little light session. I'm going to get very serious. Don't worry. Whenever I get serious, it only becomes more interesting and more fun. Okay. So, let's go to what I have learned from all of you, or what we lay people, common people, have learned from all of you. So here are some management lessons from a doctor's profession. So you might want to sell this idea to some of your patients or to your relatives, saying that, you know, this is what I can teach you about management from my profession. I think the first lesson I learned from all of you was, and I keep learning all the time, and we have a very famous cardiologist in our family, Dr. Ashok Punjabi. And he is, so when people ask us, who is your family doctor? I say, we have a doctor in the family. You know, so I don't really have to look for a family doctor. We have a doctor in the family. And we are like, anything happens, call Ashok. Go to Ashok. Meet Ashok. Just trouble him. Poor guy. You know, and all we relatives pile on in him. Now, what I observed in the way he works, and also the way all of you work, is you are able to embrace complexity. A disease is a complexity for any normal person, for anybody, and you have the idea and the knowledge as to how to handle that complexity. The complexity for you when handling patients is not just about the physical illness, it's also about their mental state. It's how you handle them, how do you motivate them, how do you give them some inputs, and how do you assure them that it's going to be fine. Yeah, like I went to the doctor yesterday, he said you will be fine. You know, so that one sentence, it makes a big difference to people like us. And to all of you, of course. So this is the first thing I learned from your profession. Embrace complexity. The second thing I learned from your profession is research orientation. If you look at the statistics in India, it's quite shocking. In America, they spend $607.5 billion in R&D activity, which is 17% of their annual research and development spend. You know, no wonder that they are so way ahead in terms of medical science, in terms of other sciences, and in terms of rational sciences. And look at India. Only 0.7% of the GDP was spent every year on research and development, on an average. This is all we spend on R&D in our country. And no wonder that there are so many superstitions around the kind of life we lead, because we are not so rational. You need a combination of rational and non-rational processes. So this is the second thing we can learn from your profession, which is research orientation. Third is, excellence comes from loving the boring job. That's what I learned from your profession every day. You have a set process. So somebody comes up with a certain illness, you know what are the basic things to ask, and what are the basic tests to be done, what is the basic prescription to be given, and it does not change. I mean, it does not happen as per your fancy. It's a routine, so-called boring job. And what I find is that successful people are those who can do the same boring job with great passion for all their life. Like our homemakers, I have great respect for them because they can do the same boring job all their life with very, very little expectation. They don't get paid, they don't get any recognition, and you have this great ability to do the same thing every day of your life without getting bored with what you are doing. And I think that's a great lesson in management. You look at Amitabh Bachchan, he's been around for more than 50 years as an actor. Asha Bhosle has been around as a singer for more than 75 years. Devanand, he died at the age of 88 and he was writing his last film script. S.P. Balasubramanian, and you can learn so much from films actually. He sang more than 40,000 songs in his career. It's fantastic for a gentleman who spent his career for over 40 years singing. And I'm sure all of you have so much experience. And I have seen doctors in my family or otherwise who have been doctors for 30 years, 40 years, 50 years, and they are able to do the so-called same boring job with the same passion. And that's what Bruce Lee said. I fear not the man who practiced 10,000 kicks once, but I fear the man who has practiced one kick 10,000 times. That's why this is a specialized conference. It's not that any doctor can simply walk in and be a part of this conference. A very specialized conference because it's meant for a particular stream. So that's what I learned from your profession, that excellence is about loving the boring job and doing it every day. Excellence is about composed passion. You see, we are motivational speakers. We are known by how animated we are on stage. We are known by the energy we bring to the table. But can you go and do a test passionately on somebody? Today I'm in a great mood. I just came out of Hariharan's session and I'm highly motivated. So I'm going to do a passionate blood test. It doesn't work like that. But you have passion. It does not mean that passion does not mean just outward expression of animation or energy or animatedness or energy. Passion is about your commitment, your integrity. It's about your love for what you're doing. So you are able to display what I call as composed passion. And that's what we require in life. You need to be passionate, but you also need to be composed. And I find this fascinating when I meet a lot of doctors, and I find patients are so animated, but doctors are so composed, and they're not getting carried away. I'm sure you're trained for that, but it also calls for a lot of, a self-management. It's a way you manage yourself. And I'm sure you're under a lot of pressure yourself. You never know when you might get an emergency call. Your family is on its toes all the time. You have taken an oath. So it's not easy. It's not easy, but we learn how to have composed passion from your profession. Process plus wisdom. You're all process oriented. You have to follow a process. But there is also something that comes with experience, which is your intuition maybe, or which is your acquired wisdom over a period of time, or which is a natural wisdom. I'll give you an example here. There is a gentleman called Dr. Mukhi in Mulund. He is an orthopedic surgeon. He is a specialist in orthopedics. And many, many years ago, when I was growing up, and I was in my teens, I had severe back pain. And I went to this doctor. My mother came along with me and we went to the doctor and we said maybe we should do an X-ray or something. Generally, what do common people fear? That I have to undergo some X-ray, I have to do so many tests, I don't know what it will cost, so on and so forth. Dr. Mukhi told me, don't worry, this is growth pain. You are growing up and your bones are adjusting themselves. Just do not worry, you will be fine in a few weeks. So you don't have to undergo any great tests. And as it turned out, it happened to be growth pain. And when I shared this with one of the other doctors, who has an understanding of allopathy but also does homeopathy, more of a homeopathy doctor of course, and he said, that's what a champion doctor is all about. That's the genius of Dr. Mukhi, that he clearly told you that this is the wisdom I want to pass on to you. It is growth pain. So don't worry about it. So the fantastic thing that we learn from people like you is how to apply the process, but also how to apply some common sense. And while you are applying your common sense and your wisdom, you are also following a process. Right? So that's the next management lesson that I learned from all of you. I love this. This is what you do every day. You diagnose the problem. You try to get to the root problem. You try to get to the root cause. And I picked up this fantastic lesson from this film, Jayesh Bhai Jordar. I don't know whether you watched it. I don't know whether I should recommend to you to sit through 3 hours of this film, but I definitely wanted to watch this particular scene where it teaches people like us how a problem is wrongly diagnosed and what disaster it can cause. So there is this village, and there is Baman Irani, who is the village head, and his son Ranveer Singh, and they are having a village meeting. And while the meeting is going on, there is one girl who stands up, and he tells the village head that, "Sir, the problem is these boys in the village are troubling us a lot. So can you please help us in a way? Because they tease us, they do eve teasing, they are not decent, they trouble us, we can't move around freely." So Boman Irani thinks for a while, he's a village head, and he diagnoses the problem as the soap. He says, "Ban the soap that you use. From today, all women in this village cannot use soap, because when you apply that soap, it sends out a very attractive smell, and that smell is attracting the boys. So the problem is you and not the boys." You see how problems get diagnosed in the corporate world? This is how problems get diagnosed in the corporate world. Ban the soap. You're not supposed to ban the soap. You're supposed to ban that bad behavior. But that's not what we do in life. Very often, we get the diagnosis wrong. And that's what we learn from a doctor's profession, that you have to get the diagnosis correct. And when you talk about root cause analysis, nobody knows it better than you. Fantastic. So, we spoke about some interesting words which were given by Shashi Tharoor. Then we looked at some very beautiful lessons that we learn from all of you on a daily basis. We looked at how you help us diagnose problems. We looked at how you help us with the process, also with the wisdom, so on and so forth. Now, here are some ideas from our management gurus. And I'd like to conclude with some of these points from the management gurus. Marshall Goldsmith, who wrote this absolutely amazing book, What Got You Here Won't Get You There. I think it applies to your profession, it applies to my profession, it applies to everybody in this world. What made you somebody good at a level is not the same quality that will make you go to the next level. What makes you an MBBS cannot make you an MD, right? And if you want to go beyond, what made you an MD cannot make you something beyond that. So you have to keep growing ahead. You have to embrace new contexts in life. And new skill sets. That's what got you here won't get you there, says by Marshall Goldsmith. Also, I'm sharing this with you because not necessarily you need to know all this or you need to apply for yourself, but these are all great lessons to share with friends or as parents. There is a great opportunity that you can go back home and have a dinner table discussion with your spouse and your children. Atomic Habits by James Clear. This is an amazing book by James Clear, and James Clear says, too often we convince ourselves that massive success requires massive action. So I want to lose 10 kg weight in the next 2 months, 3 months. So one best way to do is to fast for 20 days. You will lose 20 kg weight, not 10 kg weight. And that will get into some other kind of trouble. So he says it's not about taking massive action. It's about improving 1%, which is not noticeable, but it can be far more meaningful, especially in the long run. And the difference that a tiny improvement can make in your life is absolutely amazing. Now, I'll give my example. I have written 8 books so far. I'm a published author of 8 books, 9th on the way. I have written more than 160 blogs on LinkedIn and on my blog site. I have 250 YouTube videos. So I would love you if you can go to Hariharan Iyer on YouTube, The Entertainer, and subscribe. I'm not saying this to boast. All I'm saying is, when I share these numbers today, they look amazing. They are astounding. But they have come in the last 10 years, 10 to 11 years. From the time I started shooting the videos, from the time I started writing my blogs, from the time I wrote my first book and got it published in 2011. So when you do it bit by bit, it suddenly all adds up so beautifully. And suddenly, you have an amazing amount of work. You can remember the first patient you dealt with in your profession, and today you must have handled thousands of patients. So the 100 patients did not come on day one. But today, there could be at least 25, 30 patients waiting for you every day. It happens over a period of time. That's the beauty of developing the right habits bit by bit, is what James Clear, one of the finest management books that I have read. The Goldilocks Rule. This is a very interesting rule by Goldilocks. And again, there's a great parenting lesson also here. And also if you are mentoring new doctors. He says, humans experience peak motivation when working on tasks that are right on the edge of their current abilities, not too hard, not too easy, just right. Now, for example, if you are an amateur tennis player, suppose you go to play tennis every day, yeah, and you love playing tennis, and you also have matches with your friends, but one day your club announces who can take on Ralph Nadal. How many of you will be ready for it? I mean, there is no scope. I mean, I cannot withstand one serve of Ralph Nadal. So there is no motivation to compete. But suppose Romy sir is also a tennis player, like me, an amateur guy. I am also a tennis player. And I feel, yeah, it's quite a challenge to beat him. But I feel motivated to compete with him because I know I have a chance to win. I may lose, but I still have a chance to win. So it's not easy to beat Romy sir, but it's also not that difficult. It's not impossible. But to beat Ralph Nadal is absolutely impossible. So sometimes what parents do to their children is they impose their dreams and their unfulfilled aspirations on their children, and it starts acting like a Goldilocks rule. Because the child says, you wanted to be a doctor, I want to be a choreographer. It's not possible for me to study for so long. Forget about it. You know? So you treat your patients, I'll make people dance to my tunes. It's more or less the same thing, isn't it? No, not really. I'm just joking. So what I'm trying to tell you here is, apply the Goldilocks rule in life and check out and who is good for what. That's why I have a problem with a lot of goal-setting exercises that happen in the corporate world. Because for most of them, it's like a Goldilocks rule, or at least for many of them. I could never relate with a goal-setting exercise. It was either too hard, and unfortunately, it was never easy. It was always very hard in the corporate world. Yeah? So that's what Goldilocks rule is all about. The next one is child is father of man. I'm sure you heard about this. And in many of the motivational sessions that I do, when I ask people, what is the meaning of child is father of man? They say, जब बच्चा बड़ा हो जाता है, वो बाप का बाप बन जाता है. I said, no, that's not what it means. I mean, the psychologist who invented this term, he will turn in his graveyard if we were to give these kind of explanations. Child is the father of man is a very powerful concept because it tells you your childhood behaviors or your experiences as a child have a major impact on your adult life. So many of the adult complexities, personality complexities, emotional complexities, psychological complexities, they come from your childhood. So it's all the more very painful to see if children do not get the right nutrition, they don't get the right education. There are many orphan children who do not have families, and there are within families, there are children who don't experience a great childhood. The fundamental job of a parent is not to provide money and all the comforts and send them to the best college in the United States of America. It is to fundamentally first make them feel happy in life and who they are. And I'm sure all of you will agree, if you are happy, you are a little stress-free, which essentially means you'll be physically fine. Right? I mean, it's absolute common sense. But that's what people miss out in life. So we have to ensure that when we are also dealing with adults, to understand their childhood background. It does play a role in what they go through in their adult life. It happens to all of us. And nobody can ever have a perfect childhood. That's fine. But at least 60-70% it should be great, so that I have good memories of my childhood. So that's what child is the father of man means. Cognitive dissonance. The only reason I'm using this term here is to impress you with my intellectual ability. There is no other reason. You see, we have so much complex when we deal with doctors. So I'm trying to impress you. Okay. So for many years, I did not get this term at all. I was not able to understand. But as I was researching for this session, I came across this theory of cognitive dissonance. And I found it very interesting. It simply means people experience discomfort when they hold conflicting beliefs or when their actions contradict their beliefs. So I'll take two examples here. I'm a secular guy. That's what I believe. But if my child were to marry outside the community or outside the religion, I will object. So my actions and my beliefs are at variance. So that is cognitive dissonance. The best thing about the Western world is how they can give a sophisticated terminology to something as simple as not allowing your child to marry outside the community. It happens every day in India. So we live with cognitive dissonance. I don't know for how many years we've been living like that. Second simpler, even simpler example is, I don't believe that smoking is good for health. Smoking is injurious to health, but I'm a chain smoker. So my actions and my beliefs are at variance. So your patient, many of them must be having cognitive dissonance. They know that they have to follow you, but when they go home, they will do exactly what they want to do, against your advice. You would have said, don't eat this, don't eat this, don't do this, but they would exactly do that and come back and say, these medicines don't work. So it's actually not a problem with the medicine, it is a problem with their psychology, which is cognitive dissonance. Right? Now, I want you to guess which management guru would have come up with this theory called rice and water theory. Any guesses? Is it Marshall Goldsmith? Is it James Clear? Is it somebody else? Farmer. Okay. I'm so sorry, sir. Unfortunately, I'm not a farmer. So the management guru who has given this is Hariharan Iyer. You see, I'm trying to impress you guys. with terminologies and theories. Okay, what do I mean by the rice and water theory is you can have, last 2 minutes, you can have any amount of rice items, idli, dosa, biryani, dal chawal, you can have khichdi, and you can make any kinds of preparations. I went to one of the hotels and they even had a rice starter. I was shocked. I did not know that rice can be a starter also. They put some, cream into it, some cheese, and they made a nice starter. What is the water? What are the variations of water? In water, you can have cold drinks, you can have, other kinds of drinks, you can have juices. But at the end of the day, you get maximum satisfaction after having had a great meal in a hotel for 3 days. You have been here for 2-3 days now. When you go home, what you will settle for is a simple dal chawal. Am I right? And that will give you the maximum satisfaction in life. Despite having eaten the best buffet, breakfast, lunch and dinner in a 5-star hotel. And how much ever thirsty you might be, ultimately what will quench your thirst is that glass of water from your fridge or your aquaguard at home. Yes or no? So life is all about following the fundamentals. And that's something all of you do so very well. And the last thing is Ubuntu. It's a beautiful concept given by Desmond Tutu from South Africa, and Archbishop Desmond Tutu, a legend in his life, and he said, I am because we are. So I cannot be an isolated person. I am because you are because I am also there. It's all about a team, and I think this particular conference is all about that. All you great experts coming together and sharing your knowledge, and it's a wonderful practice of the Ubuntu principle. So we need much more of Ubuntu in our world. So we covered Shashi Tharoor's 4 words. Floxy, noxy, hilly-pillification being one of them. And we also understood what are the management lessons from a doctor's life, and also wisdom from the management sages, Marshall Goldsmith, James Clear, few other people. I put in a little bit of my own theory. Ladies and gentlemen, God bless you, and thank you very much.
Thank you so very much, Mr. Hariharan Iyer. Let me shake your hand and let me say thank you on behalf of everybody. Please come here. What a wonderful session. We wanted more of you. But as a token of everybody's appreciation, I will not give you something which can be measured in materials. I will give you a hug.
Thank you.
Thank you very much. And look forward to seeing you again. God bless you. Bye-bye. Thank you very much. Big round of applause, Mr. Hariharan Iyer.
Thank you so much.
Thank you.
Good morning to you all. First of all, I thank the organizers given me the opportunity, the CUBE team. And today is it's a small observation study which has come across in the emergency room of our hospital. In all emergency room, we usually do the peripheral smear. And if at all I not get the smear, CBC with smear, I just go and do it both and evaluate it. And here, the microcytic hypochromic anemia with increased ferritin. Usually they will they usually do the ferritin value. And in infectious conditions, right? Hypophosphatemia, all we know that, is a key acute phase reactant used for clinician as an indication for therapeutic interventions and aimed at controlling inflammation in the high-risk patients. And I'm not saying that it is an innocent bystander for controlling the infection. Its pathogenesis is low and it is as Sir said, is double-edged. The RHE is a measurement of the hemoglobin content in the reticulocytes. And in changes in iron changes in hemoglobin level and the RBC, it will take longer time. And even the other indices of the RBCs, including the peripherismia. So, cell counters with a retic mode, possibly to measure the reticulocyte content, and the RHE, a different company use different terminology also, right? This for this hemoglobin content. As early as 2 to 4 days of reticulocyte production itself, we can detect it. So it is a good marker what is so in our other iron screening parameters, right? So iron deficiency, it is usually used for the iron deficiency anemia, response of iron therapy, and in iron status in the patient with epiotherapy. Both RHE and ferritin are used for the iron evaluation in iron deficiency anemia, but increased in the but the ferritin is increased in the infections conditions also. During this period, it is difficult to assess the iron status. My aim is observation and study of RHE or iron content, what I mean to say that, and the ferritin value in critically infectious conditions. We use this instrument, one is Access, another one is BC 6800 plus for RHE. And these are the normal ranges we design in our laboratory, depends on the age, is done it on CLIA, whereas the reference ranges, which is 28.2 in 36.6, and RHE is determined in the reticulocyte channel by flow cytometry, and the mean fluorescent scatter is estimated the cell value, and simultaneously measure the hemoglobin content of the RBC. The study conducted during the period of November, during the COVID time, we got a lot of COVID patients that time. And along with that, other infectious conditions also we got it. Put together, we had 46 cases of high ferritin content and low HB, MCV, MCHC, and the high RDWs, and in infectious conditions. So these are the cases. COVID-19, 22 cases. Dengue patients also, they were, that is now it is increase in time. And of course, leptospirosis in our area little high, I believe, 4 cases we got it. Septicemic cases, 6 cases. And all were culture positive and gram negative, majority were. And we excluded 2 cases of chronic renal disease and 1 thalassemia triad patient during this. Non-case it was. This was a pie graph. And out of 46 cases, in 44 cases showed the high ferritin, but RHE value remains low. 2 cases not correlated, both were during the pregnancy, need to be evaluated further. In conclusion, we need to avoid the iron evaluation during the acute infectious phase 1. During this period, RHE value is better indicator of iron deficiency than the iron study evaluation, which is not affected during the infectious conditions, I believe. Further, large study is required to confirm all these findings. Right? Thank you.
So thank you, sir. Any questions, comments, any thoughts? Yes, ma'am.
Very good short presentation.
Thank you, ma'am.
And good thoughts. However, we know that we don't want to treat patients with iron during infectious
Infectious.
stages. So why should we do all this? I mean, Ret-HE is more important in patients who are of chronic disorders, renal failures and others. Whereas during infections, do you think it is right?
It is not necessary that's why. It's just an observation, ma'am. Observation, right.
Thank you.
Thank you, ma'am.
Okay, is there any other question? If there aren't any, we'll move on to the next paper. I invite Dr. Bhavana Chowdhury. She is a consultant pathologist at Kailash Cancer Hospital and Research Center, Vadodara, and she's going to speak to us on the study of leukemia patterns.
Thank you, ma'am. Thank you very much for the introduction, and good morning, everyone. So here I will represent the scatterogram patterns which our experience at my center with the Mindray 6800, which we are using since 2019, I think now. So we have taken a pilot study of nearby 50 cases of different hematological malignancies, which included almost the common malignancies of acute and chronic leukemias, both myeloid as well as lymphoid leukemia. Before going into the abnormal scatterogram patterns, would like to have one overview of the SF cube or fluorescent technology which we are using now. The analyzer uses the fluorescent staining technology in the DIF and WNB channel, as we all know. And the WBCs, after lysing of RBCs, get stained by the fluorescence. Such stained cells, when they passes through the laser beam, the instrument gets the side scatter and forward scatter, giving the cell size and cellular complexities. And one more parameter, that is the fluorescent, which depends on the content of the DNA and RNA of each WBCs. So with these three parameters, a cube is formed, and according to the preset algorithms of the instrument, what we get is the WBC populations in the form of lymphocyte cluster of monocytes. These are granulocytes and eosinophils. Along with that, we get much more information about the flaggings, different flags which are left shift of the neutrophils, the immature granulocytes, and one area with the high fluorescent cells. This may include the reactive cells as well as the blastoid population, if there is any. Along with that, here the population of NRBCs and platelet clumps comes, and if there are any infected RBCs, they get reflected over here. Moving towards the WNB channel parameters, two parameters of importance are NRBCs, so that the instrument gives the corrected WBC count after deducting that cells, and the basophil cluster over here. In our study, we took lymphoid neoplasm, especially acute lymphoblastic leukemia cluster, as well as in CLPDs, only CLL cases were covered. If we see the scatterogram patterns of the acute lymphoblastic leukemia cluster, the pattern was very much similar in the cases with the smooth cluster of the abnormal cells, beginning from the lymphoid area and moving upwards towards the high side scatter area, similar to that of the many analyzers. It gives a smooth teardrop pattern if we see. The another few cases with one with leukocytosis and this one with nearby normal count as well, representing the same pattern with the high fluorescent cell and the message for abnormal lymphoblast and abnormal lymphocytes over here. An interesting case in this series was this case who represented us as a pancytopenia, and looking at the scatter pattern, it was much more favoring that of the leukemia, or we need to rule out whether there are abnormal or reactive lymphocytes or something else is there in that case. So after smear study, we found 8 to 10% of the blastoid cells, and on bone marrow examination on the same day, what we found was this classical pattern of the ALL in the bone marrow aspirate. So we do have a protocol to run the marrow samples, especially the diagnostic marrow samples, so that one can prompt the further ancillary testing in such cases before the smear gets prepared in that cases. Moving towards the CLL cases cluster, same way the majority of the cases we find the similar pattern of a compact cluster starting with the lymphocyte region. But if we see carefully, it was not much more rising in the high fluorescent area. Another 2 cases of the CLL with the lymphocytosis, and the same cluster of normal, tight cluster of lymphocyte is formed and not moving much more higher. So almost if we compare ALLs as well as CLLs, the pattern were nearby similar. And if we see this case, this was one of the outliers, as we see that in CLLs it doesn't go much more in the side scatter area. The case presented with 3 lakhs of total count and such pattern. So it was suspected to have ALL or some lymphoblastic condition. But on smear examination, what was found was this was a classical case of CLL with the pro-lymphocyte population, possibly which was giving rise to this HFC region cluster. One more observation with the lymphoproliferative or CLL cases which we saw was a small cluster which was formed over here in the area of NRBCs. Though the cases were not having much more population of the NRBCs as we see in these cases in the WNB channel, a very small cluster of these events was there in that area. Possibly it is representing that of the smudge cell population in the peripheral blood which we see. Moving towards the myeloid leukemia cases. So we clustered them in the 3 categories according to the scatterogram patterns. The myeloid leukemias with M1, M2 phenotype and APMLs, and the 3rd category was AML with the monocytic differentiation. So as compared to the normal WBC plot, in AMLs what was found was a cluster extending from the lymphocyte region covering monocyte region as well as high fluorescent area. Observing the pattern in the multiple cases, we found some notching towards the monocyte region in such cases. One case which was on follow-up, the known case of AML, and on follow-up, we had pancytopenia on presentation in that case. And the classical pattern we found during the follow-up, which was suggestive of the relapse in that case. So on smear examination, 4% blastoid cells were found. Marrow examination was prompted in that case, and what we catch was relapse with 85% of the blastoid cells into the marrow. Now moving towards the pro-myelocytic leukemia, in which, as we all see, early identification and classification is of prime importance, prompting the further investigation without any delay. So majority of the cases which we covered, the same similar scatterogram pattern was found in that. Which was, we found two clusters, one in the lymphocyte region and one above the neutrophilic region. The cluster had broad-based and the scattering population towards the high fluorescent and high side scatter area. The outlier which we found was this case. On presentation, the case was somewhat representing that of the acute myeloid or myeloid leukemia with the monocytic differentiation-like pattern, as there was a cluster rising upwards from the neutrophilic region and the lymphocytic region. So it was suspected to have AML, and on smear examination, what was found was the case was APML with the microgranular variant. So now we recollect that yes, it is a classical case of microgranular variant which was represented with the high count, and possibly due to the granules and the morphology as we seen over here, the scatterogram pattern does not follow the classic pattern which we saw in the previous cases. Moving towards the category of the AML with the monocytic differentiation, in which the myelomonocytic leukemia and monocytic leukemias were covered. We didn't had any case with monoblastic leukemia in the recent times, so it was not covered with the scatterogram pattern. In monocytic leukemia, a broad-based cluster was found in which there were two overlapping clusters. If we see one starting from the lymphocyte region going upwards in the high side scatter area, as well as that covering the neutrophil area and having high side scatter. So these were the two cases with myelomonocytic and monocytic leukemias. Moving toward the chronic myelocytic leukemias, the patterns were almost similar, with the neutrophil cluster extending upward in the lateral fluorescence and almost representing the myeloid precursor population of the case, and another small cluster rising upwards from the lymphoid area, possibly representing the blastoid cells into the case. In these cases, WNB channel is helpful and it gives an idea about the basophilic population present in the cases of the myeloproliferative CML. These are few more cases of the CML. So according to the stage of the disease, whether it is accelerated phase, blast phase, or the chronic phase, there was some clustering of cells within this different area, but the pattern remained same with the broad-based covering up to eosinophil area and moving upwards in the high fluorescent area and a mature grands area. On comparison of these last two categories, there was some similarity which we found, as both of them were having a broad base with the 2 or 3 overlapping populations. But again here, the clue was WNB channel representing basophils, and there was one note which was found in the CML cases over here below the area of lymphocyte and neutrophils, possibly representing that of the basophils. So one more differential which comes with the scatterogram similar to that of CML is the leukemoid reaction. So here also the basophils as well as the further smear examination are very much helpful. So with that I will summarize that scatterograms are sufficiently distinctive and when properly observed can be used as a screening aid for differentiating the various reactive and neoplastic conditions from that of the normals. The specific scatterogram pattern along with the other flags and numerical cutoffs can prompt the smear examination and ancillary other tests and thus reducing your TAT and give efficient reports to the critical cases. In the follow-up cases also, the scatterogram study is of very much help to catch the small abnormal events and identify the early progression of the disease. So with that, I will end my session.
Thank you, Dr. Bhavna. That was very interesting. And I think one important thing that she mentioned, along with recognition of patterns, are follow-up patients where you notice subtle, small changes in the patterns which will help us identify the morphology correctly and classify them and guide the clinicians. Thank you very much. Any questions? Any thoughts? Any comments? Yes.
You have mentioned about that bone marrow aspirate running into the any
Yes.
particular preparation is required or
So we,
because we
yes,
have
yes,
particles inside.
yes, it has particles, but we have a protocol of, we pipette them in a tube and then we run them in the manual mode. So there the chances of cluster and all has never come up with the clogging of chamber or anything. And one more thing is running the cleanse mode after you run such samples. The idea behind running the marrow sample is that in setups like our center, we need to keep the turnaround time very much limited. As well as due to the workload, one have to define that which other ancillary testing will go in that case. So before the smear comes to you, we have some idea that which further investigation will be required in that case. So that is why we have decided that protocol to run the all diagnostic marrow samples at least.
Thank you for that explanation.
Any experiences from you, madam?
Sorry?
Any experiences
Yes,
from you?
I do. I'm in consensus with what she said. We also run our samples before we run flow cytometry. We run our bone marrow samples on the cell counter. Sometimes it will give a good assessment of the cell count, especially when you have a scanty sample and you want to have an idea of what all markers you can run and how much. It does help. And yes, your concern is acceptable because yes, particles can clog. So what we do is we run it on a 3-part cell counter just to get an assessment of cell count. So instead of using our main analyzer. So we do that, yes.
Thank you, madam. Thank you.
So thank you. So I invite the next speaker now, Dr. Sunita Sharma. She's a consultant pathologist at Wadia Children's Hospital, and she's going to talk to us on IRF as a predictor of bone marrow transplant recovery.
Good morning, everyone. First of all, thank you, Mindray, and thank you, the organizing team, for giving me the chance to present here. I'll be presenting a very small pilot study, which is still going on in our hospital. This is the hospital where hematology is a big section. We have 3 places of hematology. One is oncohematology, one bone marrow transplant unit, and with the pathology department. So this is a pediatric setup. We have 6-bedded transplant unit for the pediatric population only. And this study of mine is also conducted on pediatric population. So this study is about immature reticulocyte fraction. Immature reticulocyte fraction as a predictor of bone marrow recovery after transplant. So infection is a serious complication in patients who are neutropenic and under myelosuppression for a long time. Severity of myelosuppression, what we take is when absolute neutrophil count is less than 500 per microliter. In neutropenia, resolution gives idea about the immune recovery. Parameters to predict neutropenia as described earlier are oral mucosal neutrophil count, which precedes absolute neutrophil recovery, hypophosphatemia and hyperuricemia, immature reticulocyte fraction, which increases, is a marker of that precedes neutrophil recovery, which I'll be telling about in detail. Reticulocytes, these are the cells which come into the circulation and matures into erythrocytes, as we all know. Higher proportion of reticulocyte in circulation gives idea that there is a bone marrow engraftment and there is a recovery started. It contains high RNA content, and our analyzers gives 3 regions of reticulocytes, which are low, mid, and high fluorescent regions. And IRF includes high and mid fluorescent reticulocytes, which has more RNA content. And we observe time interval between IRF increase and absolute neutrophil count till 500 per microliter. So the aim of our study is to find out a parameter which can give idea that how long patient will be in neutropenic state, and accordingly how we can manage the patient in immunosuppressed condition. A parameter should precede before neutrophil recovery. Parameters should help in estimating duration of neutropenia, and severity, what we presume is when ANC is less than 500 per microliter. The various parameters, as I mentioned, oral mucosal neutrophil count precedes absolute neutrophil count, but it is a time-consuming and tedious procedure and gives very less time before neutrophil recovery starts. Hypophosphatemia and hyperuricemia, these are the parameters. Phosphate levels and uric acid levels goes 20% low to normal before neutrophil recovery. But this also is found in 60% patient upon recovery. And it can be altered with other therapeutic measures like phosphate replacement, renal failure, and allopurinol therapy. So what we have studied is immature reticulocyte fraction that I'll discuss in detail. And we need to establish the correlation between IRF increase and absolute neutrophil count increase in post-bone marrow transplant patients. IRF increase reflects erythroid engraftment, and this follows neutrophil engraftment. IRF increase is important in neutropenic patients with reference to infection control. So for materials and method, what we had post-transplant patients, it's still study is going on, but I collected data retrospectively. Daily blood counts of all these patients since bone marrow transplant till the absolute neutrophil count reaches 500. Fully automated 5-part analyzer, which has reticulocyte parameters, is required. We had 20 cases till now for the pilot study. 6 autologous transplant and 14 allogenic were studied. Prospectively followed every day CBC for IRF and absolute neutrophil count. And trend of IRF increase and ANC increase was followed. This is the analyzer which we are using, and these are the parameters, a list of parameters in which our interest parameter is IRF and absolute neutrophil count. Daily trend of IRF and ANC was observed. All except one case showed IRF increase before ANC. IRF increase preceded by 4.68 plus minus 2.4 days in all cases except one, which was an outlier and was excluded from the data analysis. This is the data which I'll explain you what we found. These are the 20 cases we followed for IRF and ANC increase. This is the graph, lower graph, which shows IRF increase. We can see here all the cases IRF has come first, and later there is increase of absolute neutrophil count, and there is average gap of 4 days in all the cases. So it proves that ANC, IRF comes early, almost good 4 days before absolute neutrophil count increases. This is in individual cases, this is the pattern. This is the IRF, and this is absolute neutrophil count increase. So in day 1 post-transplant, IRF is higher. Gradually over a period of days, it goes down and reaches to minimum. This is the day we note down that IRF increase has started. And we see the neutrophil graph, it is minimum throughout, and almost 4 days later, absolute neutrophil count has increased. So it gives a good idea at the time of IRF increase that there will be neutrophil rise in 4 days. So the results indicate IRF can predict myeloid engraftment several days before absolute neutrophil count reaches 500 per microliter. IRF precedes absolute neutrophil count 500 per microliter by an average 4.68 plus minus 2.4 days in all patients. IRF can be used regardless of equipment and would simplify result interpretation. Other parameters of marrow recovery were not as predictive of marrow recovery as IRF, we found. A neutropenic patient, for example, with fever and increasing IRF is expected to have increased neutrophil count in 4 days and can be managed conservatively. On the other hand, a febrile neutropenic patient with persistent low IRF can be targeted for intensive diagnostic, prophylactic, and therapeutic measures if clinically indicated. IRF is an early indicator of engraftment of bone marrow. So IRF, to conclude, is a simple, reproducible, inexpensive, and widely available test can predict marrow recovery several days before neutrophil recovery. Simple blood sample and an advanced hematology analyzer is required. Results are fast and accurate. Recovering IRF could suggest recovery of mucosal neutrophil and hence help in rationalizing the antibiotics early. So prospective study for assessing the role of IRF and other markers in stem cell transplant patient is still under process. Study is going on. So with all, I thank you all.
Thank you, madam. So do you report IRF routinely?
Yes, ma'am.
And what is the feedback from your clinicians?
Clinicians are following it regularly in all patients.
Any questions?
Any idea about IPF compared to IRF?
No, sir. The bone marrow transplant unit is following since many days. Only the data was not there because machine has come now for this.
So there is some data on IPF and IRF together on post bone marrow transplants. We have also done some work in our center in Delhi. What we have observed is while you've said 5 days in advance in IRF, you can add another 1.5, 2 days for IPF. In fact, IPF gives you a much earlier indication of marrow recovery. So, you know, since you're anyways running the samples in a reticulocyte mode and you're getting your IRF, it's just another parameter which you might need to take over and see in terms of the data. And perhaps in the next cube, you can present that data to us with respect to IPF as well.
Okay, we'll follow this also.
Thank you, Dr. Handu, for that. Anybody else?
Yeah.
Yes, please.
Very nice presentation. My question is just an extension of what Dr. Handu was asking.
Okay.
It's on? Yeah. What other, you mentioned that you had studied other parameters and the IRF was better than them. So what other parameters did you study to say that IRF is better than them in predicting the bone marrow recovery?
Other parameters were mentioned in the literature that they take a time, that hypophosphatemia and this mucosal neutrophil count, and they found that it is not very practical and difficult to follow.
So they were not other CBC parameters, they were biochemical
No,
parameters.
other CBC parameter yet to follow. We can do absolute monocyte count also. That also gives a good idea for bone marrow engraftment.
Thank you.
Thank you.
Thank you, madam. That was really good.
Good morning, everyone. I would first of all like to thank the organizers for giving me an opportunity to be a part of this wonderful academic event. So my topic for today is flags and newer RBC parameters of automated analyzers which serve as distinctive tools of diagnostic significance. So hematology analyzers have evolved over decades to the present modern analyzers displaying research and reportable parameters, many of which are RBC extended parameters and reticulocyte derived parameters which serve as very useful tools in the day-to-day diagnosis of various anemias. So this is an observational study of some of the newer RBC parameters and flags which are generated by the Mindray BC 6200 hematology analyzer in our department. So flags are generated by the analyzers in the presence of abnormal cells. False positive rates for flags are all high in many instances in many analyzers. So the study was taken up with purposive sampling of cases which are flagged for the presence of abnormal RBC parameters, and they were correlated with peripheral smear findings. So these are the newer RBC and reticulocyte parameters which are of clinical significance, and among these, NRBCs and reticulocyte percentage is widely being used in our complete hemogram reports for day-to-day diagnosis of anemias. Whereas the other parameters such as RPI, reticulocyte production index, FRC, RDWSD and RHE, though are being provided by the analyzers, are not being a part of the complete hemogram which is being issued to the patients. So now we studied a few of these parameters. Fragmented RBCs, as was discussed in yesterday's session, they are measured in the reticulocyte channel using fluorescent flow cytometry and is being reported and given as both absolute as well as percentages. So the ICSH recommendations for a significant schistocyte count is more than 1% by optical microscopy in adults as well as neonates, whereas for premature babies it is more than 5% which is taken as significant. Whereas the data for FRC automated fragmented red cell count was not much available except for Sysmex where the count of less than 0.5% is taken as normal. And for 3-month-old baby, the normal schistocytes are supposed to be less than 2.5%. So these were the 53 cases which were studied over a period of last 3 months, and these were the samples which were flagged for the presence of RBC fragments. So the cases include G6PD deficiency. The cases include G6PD deficiency and snakebite, which are known causes of intravascular hemolysis, microangiopathic hemolytic anemia comprising of DIC, TTP and HUS. Other cases included thalassemia, macrocytic anemia, microcytic hypochromic anemia, neonatal sepsis, and some cases of 8 cases of autoimmune hemolytic anemia. There were flags even for in vitro hemolysis cases. So among these, the cases that need special reference are macrocytic anemia and autoimmune hemolytic anemia. So we studied some of these. And to go by the cases scenario in individually, so you can see this was a 1-year-old child with dark colored urine, flagged for the presence of fragments. And on peripheral smear, we saw the characteristic blister cells, bite cells with reticulocytosis. It was a case of G6PD deficiency. And then this was another case which was flagged for the presence of fragments with FRC count of 2.8%. This was in a 3-year-old male child with a history of diarrhea, and the peripheral smear showed schistocytes. This was a case of hemolytic uremic syndrome. There was another case of thrombocytopenic purpura again, which was flagged for the presence of fragments, and this was a case in a 36-year-old male. So now we will move on to the cases of our interest, where, as I said, autoimmune hemolytic anemia cases were flagged for the presence of RBCs, and here the flag is generated for RBC agglutination as well as for flags, and this had a significant FRC count of 12.5%. So when we went back to the smear, this smear showed clumping, autoagglutination, and it was a Coombs positive autoimmune hemolytic anemia, possibly due to cold agglutinins. So this was another case. Example to show the flagging performance of the analyzer with an elevated FRC count, and simultaneously we can look at the spurious indices which are elevated here, MCV, MCH and MCHC. So autoimmune hemolytic anemias, as is known, they present with reticulocytosis, they can be spirocytes, and in severe cases of hemolysis, there can be RBC fragments, nucleated RBCs and erythrophagocytosis. So RBC autoagglutination, as seen in the case, is a well-known phenomenon that is seen in cold agglutinin-induced autoantibodies. So now, to analyze why the fragments were seen in autoimmune hemolytic anemia, we have to go back to the pathogenesis, where IgM antibodies are involved in the pathogenesis, and these IgM antibodies sensitize the RBCs, and these RBCs, sensitized RBCs, activate the complement, and final hemolysis is either through intravascular complement activation and direct cell lysis or extravascular lysis. So among these 8 cases of autoimmune hemolytic anemia, consistently the hemoglobin value was less than 7 gram per deciliter, proving that this was a case of brisk these were all the cases with brisk hemolysis. So apart from flagging for the presence of fragmented RBCs indicating brisk hemolysis, the analyzer also substantiates the pathophysiology of the underlying hemolysis. So these are the next cases of set of cases which are important. These are cases of vitamin B12 deficiency which were flagged for the presence of fragments. And in this case, there was a hemolytic process going on with reticulocytosis of 13%, FRC count of 3.5%. So now, this was a peripheral blood smear which showed a helmet cell. The big arrow is pointing towards the helmet cell and the small arrows are pointing towards the poikilocytes. So all these cases of macrocytic anemia had significant poikilocytosis associated with occasional schistocytes. So occasional schistocytes may be seen in severe vitamin B12 deficiency. However, marked poikilocytosis is often a feature and can mimic schistocytosis. The concomitant processes which lead to anemia in B12 deficiency already have been hypothesized as ineffective erythropoiesis and increased hemolytic destruction of red blood cells. So there was a study on the prevalence of hemolysis in vitamin B12 deficiency anemia which showed 27% of the cases that showed fragmented RBCs, similar to our study. So now this was a 16-year-old girl, a hale and healthy girl, one of our technician's daughter. This sample was flagged for the presence of FRCs, and that flag was noticed after this platelet count was seen of 9.45 lakhs. Can anybody guess on what is the reason for this fragmented RBCs? She had no prior history of anemia, jaundice, or features of hemolysis even at presentation. So this was a case of smear showed completely hemolyzed RBCs. It was in vitro hemolysis. The sample was transported on a hot summer day, and we were surprised to look at the RBCs, and this smear was reviewed only because it was flagged for 27% FRCs. So now another example of flagging performance for lipid particles. This was in a 56-year-old male with hypertriglyceridemia. I would like to draw the attention of the forum for this case. This is the rarest and the first case that is being reported here. And this was a 32-year-old female, came for complete hemogram, peripheral blood smear, which is showing some particles at the tail end of the smear. Analyzer results did not give any differential count. Total count was elevated by 20,000, hemoglobin 11 grams, platelet reduced. The sample was flagged for the presence of left shift, NRBCs and lipid particles. So the careful examination of the smear showed the particles to be composed of adipocytes and cellular elements. The cellular elements had megakaryocytes, immature myeloid precursors and erythroid precursors together. And the sample, because it was flagged for lipid particles, we poured the sample onto the Petri dish and observed the arrows are pointing towards the fat globules. So this was indicative of marrow elements in peripheral blood. So when we went back to the history, it was a 32-year-old female who met with a road traffic accident with complex fractures of femur and pelvic bones. So this was diagnostic of bone marrow fat embolism, and this was demonstrated in the sample that was drawn immediately 2 hours after trauma. So the time was recorded there. And fat embolism syndrome, as is known, it is known to present 12 to 72 hours after trauma with a classic triad of respiratory changes, neurological abnormalities and petechial rash. However, the diagnosis of fat embolism still remains non-specific even with the available criteria. The most accepted is the Gertz criteria of major and minor criteria. But in our case, a simple peripheral smear examination coupled with the analyzer results helped us in the objective evidence of fat embolism irrefutably. This is the first case that is being reported with ante-mortem demonstration of circulating marrow emboli, while all the previous published reported cases are on post-mortem examination within pulmonary vasculature. The case is published recently last month in IJPM. So now we will move on to the next flagging performance, that is infected RBC. And here the sample was flagged for it with even quantification of the percentage of infected RBCs, and the peripheral smear was reviewed. Actually, the diagnosis was missed in this case. Only because of the flagging, the smear was reviewed and we identified schizones of malarial parasite Plasmodium vivax and gametocytes of falciparum. So the advantages to stress upon the utility of the analyzer, they are helpful and alert the diagnosticians even with low parasitemia. They avoid serological tests to detect malarial parasite, especially in these situations, in the current situation where the incidence of malaria has drastically come down and we forget to screen the malarial parasite. So now these are some of the derived parameters. As all of us know, RDW is nothing but the red cell distribution width, which has two components, CV as well as SD. So RDW CV, as all of us know, has been widely used in the day-to-day diagnosis of iron deficiency anemia, whereas we took up a study on 100 cases of vitamin B12 deficiency anemia to study if RDW SD or CV is useful. So now this is to show the relationship of RDW CV with vitamin B12 and RDW SD with vitamin B12. Whereas the inverse relationship of both the parameters with vitamin B12 was studied, the p-value was not significant for RDW-CV, which was more than 0.005, whereas for RDW-SD, it was significant with the less than 0.005 to infer that vitamin B12 deficiency is better depicted by the RDW-SD changes than RDW-CV. So now this was the Kramer's V-test that we applied. Out of 100 cases of vitamin B12 deficiency anemia, 90 cases had elevated RDW-SD, 72 cases had RDW-CV elevation, and only 64 of them had MCV that was elevated. So this is again calculated with the p-value, which was significant that RDW-SD is a better discriminant function to detect the hematological abnormalities even before RDW-CV and MCV. So now this is another parameter, RHE, that has been widely covered. So a study was taken up where we studied 41 cases of serum ferritin, microcytic hypochromic anemia with reduced serum ferritin levels. And this is the finding where the serum RHE was compared with serum ferritin, MCV as well as hemoglobin values, and all of them had a significant positive correlation with the p-value of less than 0.005. And the ROC curve analysis showed a cutoff value of 21.3 microgram per deciliter, microgram per liter, sorry, and then sensitivity of 80% and specificity of 81% for the diagnosis of iron deficiency. And in our department, we have made it a point now to include this RHE in the routine blood count report to avoid unnecessary serum ferritin and serum iron evaluation. So this is another indicator, RPI, as earlier being evaluated. Now it is being widely given by the analyzer, which is calculated and ready to be reported to the patients. And we know the clinical significance, less than 2 says hypoproliferation, more than 2 says there is a good marrow compensatory response that occurs usually in the cases of hemorrhage and hemolysis. So now these are the examples where this was a 46-year-old male with pancytopenia. He had reticulocytopenia, and then the RPA was 0. And the bone marrow examination revealed aplastic anemia in this case. This is another case, a 65-year-old male of a known case of chronic kidney disease who was on iron supplements as well as on erythropoietin but did not respond. He had isolated anemia. His total count and platelets were normal. He again had reticulocytopenia and RPA was 0. So when the marrow was done, it showed increased iron stores and absence of erythroid precursors. This was a case of pure red cell aplasia. So RPI gives a very good indication to the hypoproliferative states. On the contrary, we have cases of hemolysis where the RPI is significantly elevated, alerting the clinician, giving important diagnostic clues as to how the patient will respond after therapy. So to conclude, the newer RBC parameters are of diagnostic significance and relevance in busy hematology laboratories. To minimize the slide reviews, they alert the diagnostician about the abnormal cells. Apart from being time-saving tools, they also reduce manual errors in calculations such as RPI. They also provide substantial information about the underlying pathophysiology. So the observations in this study recommend the inclusion of these above parameters in the final blood count report as reportable parameters. Thanks for the patient hearing.
Thank you, Dr. Rajalakshmi, for the very nice presentation, very interesting cases. And the forum is open for questions. Any questions? So if there are no questions, thank you, Dr. Rajalakshmi. I call upon the next speaker, Dr. Tina Dadu. She is a principal consultant and head hematology, BLK Max Hospital, New Delhi. Dr. Dadu, for you.
Good morning, everyone. I think there are many presentations on the topic that I'm talking on, but every time I actually speak on IPF and HFC in dengue, so I think all of you must have gotten bored. So this time I was forced to look at something else, and I looked at reticulocyte hemoglobin. But because there have been so many presentations on reticulocyte hemoglobin, I'm going to show you a different data, which is on the reticulocyte hemoglobin only. And I realized after analyzing the data that this parameter is truly underutilized. And we all must use this parameter more efficiently and do a lot of prospective studies on this. So I will be talking about the power of the reticulocyte hemoglobin for predicting thalassemia traits. So can I just... Okay. So I will not waste a lot of time on talking about reticulocyte hemoglobin as we have already discussed a lot about it. Just that reticulocyte hemoglobin is basically the hemoglobin which is present in the reticulocytes. And reticulocytes, as we all know, they basically mature for 1 to 3 days in the bone marrow and for 1 to 2 days in the peripheral blood. These are the various stages of the reticulocytes from the bone marrow stage to the peripheral blood stage. So this is what we look at. This is the reticulocyte which is in the peripheral blood, and we try and pick up the reticulocyte hemoglobin from these reticulocytes. How we measure the reticulocyte hemoglobin is, we use the scatter plot where the x-axis shows us the fluorescence and the y-axis shows us the forward scatter. So these cells which have the low fluorescence and low scatter, these are the platelets and these are the RBCs. And the cells which are on the right-hand side, which have high fluorescence, are basically the reticulocytes. So we have to calculate the hemoglobin in these reticulocytes using this scatter plot. So one thing for sure that a lot of people have also discussed is that reticulocyte hemoglobin is an amazing parameter for iron deficiency. It can be iron deficiency purely because of patient having iron deficiency, or it could be a functional iron deficiency that happens in patients with anemia of chronic disease. But clearly reflects that iron, it reflects the true status of the iron availability to the cells. one of the very, very beautiful parameters, but I'm not talking about the beauty of this parameter only in iron deficiencies. And in fact, we did a lot of data on normal CBCs also, and we found CBC completely normal, but only reticulocyte hemoglobin was low, and it correlated very well with the ferritin values also. So indicating that it was one of the earliest indicator of iron deficiency anemia. And the best part is it is not affected by any of the inflammatory processes like the ferritin or like the way ferritin increases. It is actually also a very early indicator, like unlike the MCV, MCH, which actually reflect late once the patient has real iron deficiency. And also it's a very good parameter to do basically to evaluate the effectiveness of therapy. Like you give the iron, and that's one of the first parameters to actually show a significant improvement in the reticulocyte hemoglobin. A parameter, I think there is no other parameter, no other test like this, one of the best parameters and at a very, very low cost. So, but it has a limitation. So I will actually be talking about the limitation, and the limitation is that it is also low in beta thalassemia traits. So we did a study, and in our study, basically the first part of the study was that we wanted to calculate the normal reticulocyte hemoglobin. So we took 300 samples, we ran it on the CBC analyzer for the reticulocyte and the CBC on Mindray 6060 800 BC. We did a serum iron, UIBC, TIBC, ferritin on COBAS 6000. We also did a vitamin B12 and folate levels, and then we also did a HPLC on all these cases. The first part of the study, which included the normal ones, was when all this entire data was completely normal, we calculated the reticulocyte hemoglobin in them, and we found that our values were 28.2 to 33.1 picograms. So this was the normal retic hemoglobin that we found in patients after doing all the tests. The second part of our study was, of course, that we wanted to find out what is the reticulocyte hemoglobin in thalassaemic traits. So we took a large number of samples, and ultimately we came down to about 200 samples. We ran a CBC and the reticulocyte hemoglobin on Cal 6500. We again did a serum iron, TIBC, and transferrin, and saturation and ferritin, and we did a HPLC. Now, based on this data, we actually selected only those patients where the MCV was less than 80. So we included only microcytic hypochromic, irrespective of the hemoglobin, like where there was some amount of microcytosis. Why we did that, I'll actually explain that to you later. But based on this, we actually divided the entire study into two parts. One part was when the HPLC was completely normal, there was no thalassemia trait, and the other part was when there was thalassemia trait. When there was thalassemia trait, again we divided that population into two categories. The first category was when there was a thalassemic trait, but the serum iron studies were normal, which indicated it was a thalassemia trait with no iron deficiency. The second category was thalassemia trait with iron deficiency, based on the iron studies. And the third category, of course, was normal HPLCs, but since our MCV was lower on the lower side, so this category included all the iron deficient anemics and also anemia of chronic disease. So we have not trying to distinguish here between anemia of chronic disease or iron deficiency, we put it as one category. So we found out that on an average, in our first category, where there was thalassemia trait with no iron deficiency, our average hemoglobin, average retic hemoglobin is about 21.4. In the second category, where there was beta thalassemia trait with iron deficiency, averagely the retic hemoglobin was about 20.4. And in the third category, where there was iron deficiency anemia or anemia of chronic disease also, averagely the retic hemoglobin was 21.5. Now, if I have to tell you the difference between these three 21s, I will say that the first category, when the patient had only beta thalassemia trait, most of the patients actually had a hemoglobin, retic hemoglobin of 21 plus minus 1.5. Whereas when you talk about patients who had iron deficiency anemia or anemia of chronic disease, the retic hemoglobin depended on the severity of anemia. Say, for example, if a patient had mild anemia, the retic hemoglobin will go down to 26 or 25 or 24. If it's moderate anemia, it will be somewhere around 21, 22. If it's kind of severe, then it becomes 20, 19, 18, and it significantly goes down from there. But if a patient has a thalassaemic trait, then the retic hemoglobin is around 21 only. So we thought that can we use this parameter to predict whether the patient is a thalassaemic trait or not. So to do this, we actually compared the Menzer index in these three categories to our data. So we took a Menzer index is basically MCV divided by the RBC. So we thought that we took a cutoff of 13. I mean, like we did it with 12, we did it with 13, we did it with 14. So we realized that when we take a cutoff of 13, we are actually able to pick up 79% of the thal traits in the first category. That is the category when the patients had thalassaemic trait, but they do not have any iron deficiency. The second category in which there was iron deficiency, the Menzer index sensitivity reduced to about 31%, and we could not pick up more than that. And the third category, when there was an iron deficiency, there were actually 5% cases which were falsely positive, because these were the cases where the Menzer index was less than 13, but they were not thal traits. So this was the data based on the Menzer index. Then, of course, we tried to calculate our data. And so this is what I call as the TINA factor. So we actually used the reticulocyte hemoglobin. We multiplied it with the MCV. Because why I did this was that reticulocyte hemoglobin becomes abnormally low in cases of thal trait. MCV also becomes low. So we actually put it on the numerator to reduce the numerator. And because the RBC value is always on the higher side in thal traits, we accentuated the denominator by making it RBC square. So we actually had a formula of reticulocyte hemoglobin multiplied by MCV divided by RBC square. We took a cutoff about 75. So we realized that in our first category, where there was beta thalassemia trait with no iron deficiency, and using a cutoff 75, we could actually pick up 97% of thal traits. When it was with iron deficiency, we picked up about 63% of thal traits. And in the third category, the false positivity. That means that patients who had iron deficiency and had a factor of less than 75, we actually picked up 11% cases which were falsely positive. So if we compare the data, we realize that in the three categories, the sensitivity has significantly increased if we use the TINA factor. That is from basically 79%, we increase the sensitivity to 97%. In the second category, that is the thalassemia trait with iron deficiency, the sensitivity of picking up thalassemia traits increased from 31 to 63%, almost double. At the same time, the false positivity also increased from about 5% to 11%. But still, our true positives increased markedly. So based on this, I would say that reticulocyte hemoglobin still has a lot of potential, and we can actually extract a lot more, and we can actually have more data on this and do prospective studies. And it's a very useful parameter in even predicting that the patient is a thalassaemic trait. So if I say what's my take-home message, so I want to be very short and crisp. As Dr. Anil always tells me, it should be short and crisp. The take-home message is, please follow the TINA factor, do a prospective study, give me a feedback about what you think about it, and then we can publish a lot more than this. Thank you.
Thank you, Dr. Tina. That was a wonderful presentation. And the TINA factor, I have a question.
Okay.
How many patients have you studied the TINA factor on?
Okay, so we did the TINA factor on about 200 samples because we had the data of, which included the iron deficient, which were 113, and the non-iron deficient, that means the thalassemia category with or without iron deficiency were about 100 cases total. So roughly 100 on the non-thalassemics and 100 on the thalassemics.
So that's quite a good
So
number.
200 was this, and this we had the entire data. We had the HPLC and we had the serum iron studies also on them.
I think that should be published.
That should be published. I think it's a very, yes, I think. But we want to do a prospective study using this cutoff.
With more number of cases, I think the authenticity also.
Yes, exactly.
Congratulations on that.
Thank you. Yes.
Did you try modifying the Menzer to TINA?
I'm trying to
divided by RBC square.
By making it RBC square, yes. Actually, I applied a lot of formulas. In fact, the first formula that I started trying was the retic hemoglobin versus the hemoglobin, because the retic hemoglobin goes significantly down compared to the hemoglobin. But we didn't, like, statistical analysis did not give us a lot of results. So we applied a lot of formulas, but then we finally reached the formula of our retic hemoglobin with MCV and RBC square. So we're trying to improve Menzer. So I can say, I can give some credit to Menzer for this for sure. So I can call it like a Tina Menzer factor.
Excellent presentation, Tina.
Thank you.
It's a good marriage between ret hemoglobin and Menzer index.
Yeah.
But I have a question. Did you try with some other factors like Srivastava index or Sehgal index?
No.
Okay, because all the studies between Menzer to your
Yeah, I know. But see, Sehgal index, and actually there was a time actually when I was with Kunal at that time, and we tried to create a Dadu index and a Sehgal index that time. So we actually had a lot of thalassemia data, and then we tried to, obviously, it's all modification of the Menzer index when we are trying to use either the RBC or we are using the MCV and, the RDW. So we are just trying to modify all those factors to create an index. But I have not compared because, I think that Menzer index is still a very sacrosanct index and has not been replaced by any other index. And this is a new parameter completely away from the indices which have been there till now. So I'm trying to just sort of, again, like the way you said, it's like a good marriage between Menzer and retic hemoglobins. We should try and explore that a little more now.
You try with the Srivastava index, it is more sensitive than Menzer.
You think so? Can you give me a little bit details about that? Because I have not compared the Srivastava index at all.
I'll share it with you.
Okay, we'll do that. Thank you for the inputs, and I think I should compare the data with Srivastava index also.
Any more questions?
Sorry?
Modification to Tina's index.
Okay.
There are no more questions?
No more questions? Okay.
thank you,
But
Dr.
please
Tina.
do a prospective study and give me the feedback. I'll be happy.
Yeah, please
Thank
follow
you.
her advice. Thank you.
So thank you, Dr. Tina, and thank you, Dr. Shabnam Ruhi. So moving ahead, due to lack of time, like we are running fast. So may I call Dr. Shankar on stage, please? So he'll be chairing the next 3 talks. So over to Dr. Shankar.
Thank you, Shama. We move on to the last session of today, and this is going to be on platelets. And as we all know, like the RBCs, the platelets have a size, a shape, a staining pattern, and a number. I'm sure these talks are going to focus on all these 4 aspects. May I call upon Dr. Mamta Soni, Senior Consultant and HOD Apollo Hospitals, Chennai, to give the first talk on budding, blooming, blossoming of reticulated platelets, an evaluation study.
So all set? Can we move back to the first slide? Yeah. So good morning, everyone. By the time they are ready, I think they are ready. I thank the organizers for providing me with this opportunity to speak on something which is not so much spoken about, that is platelets, and that too reticulated platelets. And I'm sure everybody would agree with me, whosoever is present in the forum, then when we are prepping for this kind of a talk in this kind of forum where there are eminent hematologists, core group, core scientific group, we also learn a lot while in the process. So this is what happened to me when I picked up this topic. Shama called me and she actually told me, no ma'am, we are not getting enough topics for platelets. Please speak on platelets, something like immature platelet. I said platelets, cytomorphometry, I can speak on thrombocytopenia causes, pseudothrombocytopenia, thrombocytosis, qualitative disorders, so on and so forth, but cytomorphometry in platelet is very limited. She said, but it will be nice if you do so, and I just wanted to honor that, request. So what I did was I took up some data from our analyzer, and I was shocked. I would say I was embarrassingly shocked, And in Dr. Handu's language, it was blasphemous, because so much of the information, so many parameters the analyzer was giving to me on the face, and I was jolly well good ignoring it all. I mean, I was not really looking into it with so much of intent. So I thought, okay, let me look into these parameters and see if we can derive some information which we can give back to our clinicians. And so we took up a study, short period of time, so it was a pilot study on some 73 samples. I wish to take it further because we have got encouraging results. So we focused on we had some 12 parameters, some new, some old platelet parameters, and I took it on reticulated platelets. So how do I move the slide? Green arrow, right? Green button. Yeah. So reticulated platelet, most of us know that these are immature forms or early platelets released from the bone marrow into the peripheral circulation. They contain remnants of RNA, and it has been hypothesized that they can indicate thrombopoiesis and help to ascertain the cause of thrombocytopenia. So aspects related to the identification of immature platelets termed reticulated platelets date back to as early as 1969. That time, nucleic acid dyes allowed the detection of younger platelets using an optical microscopy. It was a very tedious process, and we have a lot of papers published from that time. Thiazole orange dye flow cytometry and the strategy of the gate were introduced much later in identifying the reticulated platelets. In recent years, however, our work has been made much easier, as some hematologic analyzers have made it possible to detect newly released immature platelets, but still these things are not standardized. We have speakers who would say that they are no more valid. We have people who are saying that, oh, they are very, very valid. So something concrete or standardized has come up. So just a little bit of an information on platelets. Like in healthy humans, roughly 1 billion platelets are produced and destroyed per day. That is mind-boggling figure. The rate of production can be accelerated up to 10 folds in the conditions of an increased demand. Whereas mature platelet persists in the circulation for 7 to 10 days, reticulated platelets have a much shorter lifespan of less than 1 day, and that is why they are considered as a more robust indicator of thrombopoiesis. An inverse relationship between platelet count and mean platelet volume exists during steady state conditions, keeping the total platelet mass constant. Now see, these are the parameters which I get from my analyzer, and I'm sure any high-end analyzer is giving to you so much information on platelets, so why should we not talk about them? Very much we should talk about them. That is platelet distribution with platelet grid, MPV, MPM, large platelets. These are something which are very common, which are present even in the second line of hematology analyzers. But something like a reticulated platelet percentage as well as counts, reticulated platelet threshold, volume index, concentration index, and NACU count, that is nucleic acid containing units. These we get only when we run the CBC in a retic mode. So that is something which is done as a second step. Now, what is the reticulated percent and how do we calculate it? In our analyzer or any good analyzer, high-end first-line analyzer, it is done in the retic channel. Using the same staining reagent without any impact on throughput, done just by additional software features, done by making visible what is inside this empty box. If you do not run the CBC in the retic mode, this box is empty in the platelet absorption graph. So here where we get this reticulated platelets. So same hardware, same reagents, same speed, additional information without any cost. So it is the number of pink signals in the reticulated platelet gate here. And one signal, that is one dot, represents approximately 100 platelets per microliter. So if we see here, we have got a platelet count of 29. So in this particular CBC, 29 into 100, so 2900 are the reticulated platelets. And there is the percentage, which is, of course, it is divided by the total number of platelets. So this is how it is. Reticulated platelet percent is calculated using the reticulated platelet count coming from the platelet absorption scatter and the platelet count which is coming from the platelet scatter. Whereas when we are running the CBC without the retic mode, it is this which we get. Once we run the retic mode, we get this. VI and CI, that is the volume index and the concentration index of reticulated platelet, is something which is used using a software algorithm, and that is beyond the scope of today's presentation. NACU count, which is here. So this is how we get the reticulated platelet percentage, both from the platelet scatter as well as from the platelet absorption scatter. And NACU count represents all particles below the reticulated platelet, that is, from this area, significant absorption and a very low refractive index. So all these things like bacteria, fungus cells, RNA coming from lysed RBC, DNA strands coming from destroyed WBC, etc., they all go in there. NACU is nothing, but it is nucleic acid containing units. As these signals are cells or just released nucleic acid strands, there are, say, again, the number of signals multiplied by 100. So if there are 90 green signals, it is around 9,000. So again, NACU is beyond the scope of today's presentation, but this is something which is used using certain software algorithms for the detection of something like a malaria parasite. So with this, with so much of information given to me, like 12 newer and not so newer parameters in platelets, I just thought, okay, we'll just do an observational pilot study. The primary aim of the study was to establish a biological reference interval for the percent reticulated platelets. That's the most important thing, because till the time we know the normal, we would never be able to detect the abnormal. So of course we did it on a smaller sample size, because as I said, this all started after Shama insisted that there has to be something on the platelets from me. So we just did the normal reference interval on 20, but I plan to take it up on 120 normal samples. To evaluate the clinical utility of percent RP to indicate the etiology of thrombocytopenia, so that was my second aim, and to establish a cutoff for percent RP in reduced production and increased destruction with the help of receiver operative characteristic curve analysis. So these three were my primary aim, and secondary, of course, was to analyze other associated parameters like an RP count, RP threshold, volume index, CI, and the NACU count. Material and method simple: 20 samples sent for routine full blood count in EDTA vacutaneous with a platelet count which was within our verified biological reference interval, that is 150 to 450,000, and with no known underlying pathology were used to determine the reference interval. Percent RP measurements were recorded for 48 patients with platelet count which was in thrombocytopenic range, that is less than 150. Percent RP measurements were recorded for 5 patients with platelet counts more than 450,000, just to see that there are no interferences when the platelet counts are high. Quality control and maintenance tasks were performed as per the laboratory defined guidelines and, of course, manufacturer's instructions. Sample size, as I said, was 73, normal 20. Reduced production were 24, out of which 8 were aplastic anemia, 12 megaloblastic anemia, 4 were acute leukes. Increased destruction, 24 patients, 17 ITP, idiopathic thrombocytopenia, 2 were TTP, and 5 were DIC cases. Thrombocytosis 5, most of them were unexplained thrombocytosis, and the study duration was only 3 days. These were the results. We did a statistical, good, robust analysis, whatever we could do on those 73 samples, and these were the results. We got it for almost all the newer reticulated platelet parameters, but we focused on the percentage RP. The percent RP, we were able to find out a normal reference interval, which was 1.08 to 3.98% with a mean there. In cases of increased destruction, that is ITP, TTP, and DIC, we found the range as 11.01 to 37.65, which is significantly high. Reduced production, that is aplastic anemia, megaloblastic, acute leukes, it was low, 1.58 to 10.87. Thrombocytosis, it was much lower than even the normal reference interval, that is 0.66 to 2.1, and all these had a significant p-value amongst them. This is just a graph of that ROC curve, coordinates of the curve, test results variable. This we utilized right now for RP percentage, but I would extrapolate it to the rest of the newer reticulated platelet parameters as well. And this was the result. AUC, that is area under the curve for reticulated platelet percent, was 0.950 and was significant. P-value was less than 0.001. And from the coordinates of the RP percent based on urine index, we got 11.71% as a cutoff value with a sensitivity of 90% and specificity of 91.7, which is impressive, to differentiate etiology of thrombocytopenia as increased destruction against reduced production. So in simple words, if your RP percentage is more than 11.71, you can know that, okay, this patient probably is a case of ITP, TTP, or a DIC, or anywhere where there is an increased destruction in the peripheral blood. If it is lower, you can think of the other causes, specifically aplastic anemia, megaloblastic, and more commonly in acute leukemias. So basically, conclusion was biological reference interval we were able to define, which is not available in the literature. RP percent values tended to be much lower in case of reduced production, like aplastic anemia, etc., than in cases of increased peripheral destruction. ROC 11.7% as cutoff with sensitivity of 90 and 91.7% specificity to differentiate the cause. And rapid automated measurement of the percentage of reticulated platelet when combined with other clinical and laboratory parameters can become a very useful and cost-effective tool to differentiate the causes of thrombocytopenia. Next, of course, the next plan as I go back today, it would be study on a larger sample size, multi-center prospective study, inclusion of other newer parameters also in the detailed analysis. Correlation with IPF is something which I would like to take up. And validation in prospective trials to establish the clinical benefits of reticulated platelets in coronary artery disease, sepsis, antiplatelet therapy, recovery post-chemo, and stem cell transplants, etc. When I say this, okay, it's nice to talk about these kind of newer parameters in the forums like this where the affordability is not so much of a question. We are in a way blessed and privileged that we come from labs where, we can do what we wish to do in terms of research and developments. But in cost-constrained situations, limited situations, especially in a country like ours, there can be a lot of, challenges while applying these newer parameters, and they can be like lack of an established reference value for the normal population. Technologies and the nomenclature of new indexes vary according to the manufacturer, making difficult to compare numeric results obtained from the different analyzers. So there's no harmonization in terms of, even in IPF and RP percentage, more or less they are almost similar. But it's difficult to correlate a data between the two, and till the time we do that, we are not able to have a standardized process to indicate the causes. And of course, some of us who use multiple analyzers, multiple make analyzers, like we may have a battery of analyzers from different makers at our centers, we should take up this kind of a study where we are correlating the similar parameter with different nomenclature and different numeric value to ascertain and harmonization. Availability of quality assurance material is always a challenge. We do not have, even if we are running it on a QC mode, we do not have a reference interval with which we can actually validate that it is within the limitation, within the quality control reference interval. Accreditation requirements, of course, because they want a set of things. Once you release these reports on the patient, you can't really have it as not in the scope of NABL, I would say that, because then they would like you to print it on a separate paper, and that becomes very, very inconvenient for the clinicians. Regulatory requirements, FDA approval, especially in high-end, I think anywhere, certain requirements have to be in place, regulatory requirements to use the parameters for patient use. Cost is always a limitation in our country, and the training of the staff to pick up, because they are the frontline warriors when it comes to all these things, and if they do not pick up, it doesn't come to our table. And it's almost impossible for us to kind of look into each parameter which gets generated from our hematology analyzer. To strengthening the staff, attritioning staff is always a challenge. So with this, I would conclude, short and crisp, as Dr. Handu says, but a lot of, take away from this for all of us, we can take it in a bigger way as a multicentric prospective study, and we should always talk about newer parameters, be it reticulated platelets, be it reticulated hemoglobin, or anything else. So thank you for all your time. Acknowledgement, of course, always to the department staff, all of us cannot function. When we are here talking about it, somebody else is handling the cases on our behalf. Patients always, times before COVID, some of my staff who always so very much motivates us and, makes us do even better job. Thank you.
Thank you, Dr.
Dr.
Soni.
Shabnam, can you identify few? Yeah.
It was a wonderful talk, and we enjoyed you entering into a deep area and bringing out very specific findings in that. We all know that mature platelets indicate megakaryopoiesis in the marrow. So here is an area where, without putting the patient to much difficulty of getting a marrow, we can actually use these parameters to actually save, like it's like doing a skin biopsy to save the skin of the patient, making a specific diagnosis with a little drop of blood. So I really congratulate you, and on that, my request to ask any questions on this paper.
Any questions?
Excellent study. It's the duration is 3 days, so I won't ask much critical questions, but few comments.
Yes.
To me, it appears that immature platelet fraction and reticulated platelets are no different, because basically you are checking the RNA content of the platelets in its immature form, just like you have reticulated RBCs. That is one. Second thing is, you have just included 5 patients of thrombocytosis. You see, you know that when there is iron deficiency anemia, many patients will have reactive thrombocytosis, even to the extent of crossing 600,000. So if you would have included more patients of thrombocytosis, and your reticulated platelets would have given a discriminating feature as to how you can differentiate neoplastic thrombocytosis and reactive thrombocytosis. Reactive thrombocytosis is also seen in inflammatory states. So other than looking at the thrombocytopenias, I think it will have great utility if you could study thrombocytosis, because you have essential thrombocythemia count is 9 lakhs. You have very rarely iron deficiency induced reactive thrombocytosis to the extent of 7-8 lakhs. India is a country where iron deficiency is extremely common. And when you look at a myeloproliferative neoplasm, particularly the MPNs like MF and ET, you'll find large number of platelets in them. And I suppose that they also will be high in the content of RNA, because that is also accelerated thrombopoiesis in the neoplastic setting. So that's my thought.
Yeah. Maybe I intend to take a thrombocytosis different reference interval. Out of the 5 cases which I took, 3 were essential ETs and 2 were iron deficiency. At our center, it's rare to find, those kind of iron deficiency anemia which are having thrombocytosis, but still I could gather these 5. But yes, as you rightly said, maybe we can take it in a stepwise manner and create a biological reference interval for thrombocytosis, and then a biological reference interval for benign causes of thrombocytosis against a chronic myeloproliferative disorder. So that's an excellent suggestion, Dr. Mishra. Yeah, thank you. Any more questions?
In settings of thrombocytopenia, to differentiate between ITP or peripheral destruction versus the giant hypogranular platelets of myelodysplasia, can it be a useful parameter?
I'm sorry, is this a comment or a question?
It's not a question. So, to differentiate between ITP or the thrombocytopenia scenarios, to differentiate between the peripheral destruction versus the giant hypogranular platelets as you see in myelodysplasia, can it be an useful parameter?
Yes. I mean, I have to take up a study. on
Definitely,
that.
definitely yes. Definitely yes.
Because right now it's like just increase destruction and reduce production. And then a thrombocytosis, just 5 cases, but now,
Because
we have to expand it to
The
further.
thing is that nobody looks at the platelet morphology in myelodysplasia. But the giant hypogranular platelets is a relatively predictable indicator of myelodysplasia, which if can be detected on the cell counter data, then that will be a good
But actually, I would tell you, because we have a lot of these northeastern patient and eastern patients who have just enormous sized platelets. So I actually took up, because they were all coming as 30,000, 40,000 on counts, and then when you see the peripheral smear, they're going to 120 and 150 and even more. But I was not really getting very convincing results with them. So I just thought that these people are somewhere confounding. They were neither here nor there. Some of them were having a higher percent RP, and some of them were not having. So I think a separate study needs to be taken on these spurious causes of thrombocytopenia, which can be because of these macrothrombocytes and stuff like that. Yes, so much. So all of us can gather together, and each one of us can take one topic and present it in next Mindray meet or cube or wherever.
Actually, thank you very much, madam. We'll conclude here because this is a very controversial area, as you have pointed out. What is immaturity versus what is giant, large or megathrombocyte? This has been, this controversy has been reigning for a lot of time. So we may take an entire day to till solve that. I'm sure more papers will come out of this.
And so I'm so happy that the platelets are discussed so much. So that is again.
It's a great thing. It's a great thing. Thank you, madam.
Thank you. Thank you for your time. Thank you.
I will call upon the next speaker, Dr. Shija, who is from Kottayam Medical College, my own college. She will be presenting 2 cases on platelets and coagulation disorders. Platelets, as we know, have not 4 dimensions but 6. As I said, size, shape, staining, and a number. But there is a 5th dimension, which is function, and a 6th dimension, which is its relationship to coagulation. So I hope these cases will focus on the 5th and 6th dimensions of platelets.
Thank you, sir. Myself is Dr. Shija. So we are presenting 2 interesting cases from our own experience on platelet and coagulation disorders. So first case is a 6-year-old child presented with an hemorrhagic conjunctivitis. She gives a history of profuse bleeding following minor injuries, and her family was woke up, and her brother also gave similar history. All other, his parents as well as the younger sister is there. They are free of any bleeding diathesis. The histogram. How should I change? Okay. So on examination, she is poorly built and nourished with 2nd degree standing, and general examination otherwise was normal. And on local examination, she had ecchymosis and conjunctival hemorrhage, and bleeding from the gums were there. Then on observation, we proceeded in the laboratory investigation where her her laboratory investigations, hemoglobin was reduced only 4.8 gram at the time of admission, and platelet was 1.1 lakh, showing mild thrombocytopenia. Otherwise, it was normal. And she was managed with hematinics and all. So her hemoglobin started improving, and the platelet count was spontaneously corrected. So iron studies suggested iron deficiency anemia, and other investigations were within normal limit. So peripheral smear, as expected, it was hypochromic microcytic anemia, mild thrombocytopenia, few giant platelets were seen. The coagulation profile done was apparently normal. So bleeding time, prothrombin, APTT, all were normal. So considering her hepatosplenomegaly, a bone marrow was and thrombocytopenia, a bone marrow was done, which didn't yield much information. Then during the course, as I said, she was better with hematinics and all. Bleeding manifestations were managed with the desmopressin nasal spray. So she returned. But after 1 month, she presented again with the ecchymotic patches on her shoulder joint. This time RBC parameters were low, but better than the previous one, HB 8 gram, and all these RBC parameters were towards the lower limit, but compared to the first time it was better. Then total count showed mild eosinophilia, platelets were normal. So this is RBC histogram. WBC scatter plotter shows mild eosinophilia, and the platelet parameters, so the count was normal, PLCR and PLCC were high, and which was supported by the peripheral smear also. There were many hypochromic microcytic picture with scattered platelets with occasional giant platelet. And this is the platelet histogram, which showed shifting towards the RBC curve, suggesting large platelets. So with the history, with the history of repeated bleeding, a normal platelet count, we thought it's a platelet function abnormality. So bleeding time and other investigations were done, and clot retraction test done was showed a poor clot retraction. So poor clot formation and retraction was seen with the control test. So again, going back to the detailed history, she gave a history of melena, and her brother gives a history of profuse bleeding, and her great-grandfather died because of a bleeding PR. So with this history, we tried to investigate her family members, and her brother showed an increased bleeding time and a poor clot retraction test. So we tried to construct a pedigree chart which shows the pattern of autosomal recessive inheritance. So the coagulation screening done, all were within normal limit. Then platelet function analysis was done by sending the patient to CMC Vellore, as it was not available in our lab at that time. So with the platelet function analysis showed increased closure time for collagen ADP and collagen epinephrine, suggesting a positive screening test for platelet function anomaly. Then the light transmission platelet aggregometry was done, which this is a normal aggregometry, as you all know. And now with all the platelet agonists, platelet aggregometry was tested, and with the arachidonic acid, this is a curve got, and this is one with ADP, low concentration as well as high concentration. All this showed a reduced flat curve, we showed that there is no aggregation. Then with collagen and epinephrine, the similar picture, but with ristocetin, low concentration, there's a flat curve, but with higher concentration of 1.25, their aggregation has happened, so suggesting a ristocetin sensitive platelet disorder that is suggestive of a Glanzmann's thrombasthenia. So all the other platelet agonists were within normal limit except ristocetin with a higher dose. For the completion sake, we worked up all this coagulation factor assay and own Billy-Band factor, all were within normal limit. So flow cytometry was done for confirmation, where CD41 showed absent expression. This is a normal CD1 expression, whereas in the other one, you see a absent CD41 expression, which is very much diagnostic of Glanzmann's thrombasthenia. This reverse pattern is usually seen in case of Bernard-Solier syndrome. So a diagnosis of Glanzmann's thrombasthenia was done, and the child is doing well. She is advised to restrict outgoings and to attend the OPD if there is any bleeding manifestations occurs. So the take-home message, this is a platelet aggregation response. So in our case, absent response to ADP and collagen with transient response to ristocetin. So that suggested thrombasthenia, and the flow cytometry confirmed our case. So this is this is how this von Willebrand disease and Bernard-Solier syndrome all can be worked up with using this platelet aggregometry. So the take-home messages is for a platelet disorders. In case of a suspected platelet disorders, both the family history as well as drug histories are important. And if there is a family history, you have to try to plot the platelet histogram and a pedigree chart that will help you to form a diagnosis and the type of inheritance. So a sequential logical approach of a bleeding disorder will give you a diagnosis in many of the cases. Now going into the second case, it's on it's a coagulation disorder. Here a 22-year-old second gravida at 32 weeks of gestation presented with an episode of seizure and severe headache, which are all of sudden onset. Her obstetric history, she had a previous LSCS. All other investigations were within normal limit. Her fetal ultrasound, all were within normal limit. But at the time of admission, she was hypertensive and fetal heart sounds were not localized. So an emergency ultrasound scan was done, so that showed an intrauterine fetal demise. So a patient gravida presenting with neurological manifestations, bleeding as well as intrauterine demise. So urine routine showed albuminuria with plenty of red cells. Then blood routine, there was leukocytosis plus thrombocytopenia. Platelet was around 48,000. So the RBC histogram was within normal limit. Differential count, leukocytosis with neutrophilia. Then platelet curve, platelet histogram showed shift towards the right side, showing large platelets. Now LFT done showed hypoalbuminemia with mild derangement of liver enzymes. RFT and other investigations were within normal limit except rise in CRP. Coagulation screening done showed D-dimer and all other parameters were within normal limit including PT, INR and APT. So since D-dimer is a non-specific one and there is no other contributor factor, she was managed symptomatically as well as an emergency LSCS was done considering the IUD and eclampsia. So peroperatively, she developed an intrauterine hematoma. Now, after 5 days of discharge, she again came back with headache and giddiness. There is no lower limb pain. There is no loss of no weakness as well as there is no neurological deficit. She was investigated. The urine showed albuminuria. With blood investigation this time, hemoglobin was low, maybe because of the surgery and intrauterine hematoma. CRP was raised and platelets were within normal limit. Now an MRI, brain as well as MRV done, which showed multiple infarcts in the cerebellum and the temporal lobes, etc. And a dural venous thrombosis was seen. So the coagulation workup done at this time and shows an elevated APTT, prolonged APTT with a very high D-dimer. In the initial setup, we didn't thought of a antiphospholipid antibody syndrome and all, but mainly we thought of TTP and thought it was an eclampsia with HELP syndrome. But now with this prolonged APTT and D-dimer, we proceeded to all these ANA workup. Okay, all these ANA as well as antiphospholipid workups. There we done a lupus anticoagulant profile with sensitive APTT as well as DRVVT. Both this was DRVV screening done as well as the confirmation done, but the ratio was normal. So 1.15 seconds only, if it's, that is less than the expected normal value. So since both these tests, both lupus anticoagulant profile and dilute Russell Viper venom test, both were negative. So an anticoagulant, lupus anticoagulant present was excluded. Now antibody screening done were serum ANA done was negative, and anticardiolipin antibodies done with both IgG and IgM antibody both were raised, and beta-2 glycoprotein was towards the upper limit of normal. So according to the Sydney revision of Sapporo's criteria, one clinical as well as one laboratory criteria is emerged for a diagnosis of APLA. Here, two clinical condition and one laboratory criteria was there. So final diagnosis of an antiphospholipid antibody syndrome was done, and the patient was asked to repeat the test for 12 weeks. But unfortunately, we couldn't do that because without stopping of warfarin in such a patient is very difficult, and she's continually on anticoagulant, and she developed intracranial bleed. So the take-home messages are, though all the criteria are not fitting for a coagulation disorders, that should always be kept in mind, because that's quite for the diagnosis, many times is life-saving. So this is the algorithm, and now I should thank my professor and HOD, who is now the principal of our medical college, as well as my colleagues and the Mindray team for giving us an opportunity to present the case. Thank you,
Dr. Shija. Those two nice cases. The first one was eliciting the functional aspect of the platelet, which are very quite rare diseases. The second one actually showed the two sides of the coin, that is coagulation and platelets, which go hand in hand. Any questions or comments from the audience on these cases? If there are no more questions, yes, madam.
Thank you,
Yes, Sita
Shija.
Lakshmi, madam.
Just have one small comment on your case one. Just you could do a simple test as a part of your routine screening, which will be a finger prick smear to look for platelet aggregates. It's very useful when you evaluate patients, and that's the first clue that you would get towards Glanzmann's thrombasthenia. Platelet count will be normal. All the bleeding parameters, PTA, PTT normal, but it's very important to look at a finger prick smear, look for platelet aggregates. That'll
Actually,
give
we
you
have done, madam, we have done the direct capillary blood, and there again, there is no platelet clump. The count was adequate, and platelet was seen singly.
Thank you.
Thank you, madam.
ma'am.
Nice observation. I do remember a terrifying Glanzmann's presentation of a twins who presented with puberty menorrhagia, both at the same time. And whether this is autosomal recessive was a big question at that my mind. Whether can it have another type of inheritance? It actually happened, and it was proved also. So thank you for sharing your experience. Before we go to the last case, there is a small presentation.
No, thank you. Just 30 seconds. Yesterday, Dr. Indrajit Kalita was not there when he won the prize. I want to invite you to kindly come and accept the prize of yesterday. He dressed up so well. He did a wonderful performance, and then he was not there when we announced his prize. Please give him a big round of applause. Thank you very much. Please come up. Please come up. Please come up. Sir. So may I invite you to give the prize to him, please? Thank you. In the center. Yeah. Dr. Indrajit Kalita for the best dressed theme and for the best dancer. He danced so well last night. Thank you. Congratulations. And kindly proceed, sir. Kindly proceed.
Thank you so much for this. I come from Northeast, where this discussion of platelets is very important. Apart from all the dances that I've done, I've learned a lot. Thank you so much.
Do you hear me and do you see my slide?
Yes, we can do that.
Okay, perfect. As it is this year, the idea to discuss very important topics that provokes questions, discussions between the laboratory hematology experts. And I am very happy to collaborate, even if it's online, from Switzerland, with this interesting panel of questions and discussions. How you want me to deal with that? What is the role of you I will begin with the first question, that is, what are the various utilities of optical fluorescent channel on hematology analyzer? Dr. Anil Hadoo, do you want to give us your opinion about that?
Well, I'll open the batting, no problem. So as far as the optical channel is concerned, I think the ball has been very nicely set rolling by Dr. Mishra in the previous, after the previous talk, where it was very clearly mentioned that perhaps the biggest and the best utility of the channel has been seen in the platelet mode, especially the retic mode when you run the platelets there, and you're able to get your immature platelet fraction from there, and then of course the other parameters which come on platelets. Other than that, we've also seen through the morning and even yesterday when people were talking about the reticulocyte channel giving us various information including the red hemoglobin, IRF and stuff like that. So I think as a channel, this channel particularly has got a huge utility. There is also the option of optical RBCs now on some of the analyzers, which again gives you a lot of information to deal with the disorders. And therefore, as a channel, if I look at it, it gives you plethora of information which can potentially be used. I hope that answers the question.
Yes, and let me now explain my opinion about that. I think in platelets, we were listening a few minutes ago that the NPV is a very important parameter and impedance is really very useful in hematology. It's true. But we have seen that many cardiovascular doctors are using MPV as predictive of myocardial infarction because it's increasing in myocardial infarction, but also even in venous thrombosis. But in the same way, the MPV is increasing when there is immunothrombopenia or in a macrothrombocytopenia, but the MPV is big for different reasons. One is big in thrombosis because the platelets are activated, and with the activation they have some pseudopoda that increase the size of the platelets, and it's not the same when the platelets are young and are bigger, and it's absolutely different. But how to deal with that? And in addition, what happened in the high MPV of myelodysplastic syndromes with ineffective thrombopoiesis, that the platelets are big but are many times degranulated, dysmorphic, and so on. For this reason, fluorescence adds not only the avoiding the interference of small red cells in the platelet counting, but also helps to differentiate between several reasons of high MPV. And in my opinion, today it is important to use it in combination with MPV for sure. MPV is good for screening, but after to have an optical count will be a must to have for platelets, for red cells, and for all the cells. What do you think about that?
So, yes, I agree with you. I think if we are going to use more parameters together, the answer to differentiate the diseases would be better, no doubts about that. But when I look at optical channel in isolation, I think there were previous reports, in fact, Dr. Nair would talk about and say that, optical channel may not be that perfect also at the same time, because there are these small little platelets which are not counted because you have cutoffs which are placed in certain regions in the optical channel. So perhaps a combination of the optical channel with the impedance channel together might give you a better information. And I would obviously agree with what you just mentioned.
Yeah, but and this is the important point. As you see, every MPV is calibrated, is much more stable. Optical plate, and the idea is to use the best of each technology, and for the differential diagnosis to use the combination of them. But for counting, we will decide what to use depending the histograms. Very good. Yes, absolutely. In this case, if there is no any other comment, Dr. Chopra, or any other comment, we can go. Any of the other experts here have any other comment to add?
I guess no further comments on this question. We can move to the next one.
Okay, good. What
Can
are the barriers?
Can I intervene, Dr. Ramon?
Yes.
There are, I think you have not displayed the PPT I have recently sent you. So.
Let me see. Sorry, let me see.
Yeah, there are questions which are for particular doctors, for a particular panelists.
Okay. Let me see. Yes, here, it is true. I have not. Yes, it's true.
Yeah, so we will go through only those, brush up only through those questions, since we have lack of time.
Okay, good. What are the various utilities? Can you see that? Let me see.
No, you have to share screen.
Yes, I can see that. It's a little complicated today doing that from the distance, but we will see.
Yeah.
Okay. Yeah, the question from Dr. Suri is, what are the various utilities
We have
of
to
optical
move ahead
fluorescence?
because this question
Yes.
is already done.
Yes. What are the various methodologies for assessment of red blood cells or hematology analyzers? And,
So Dr. Ramon, I think I did talk about it in my previous answer itself, where I did mention that you have primarily two major methodologies. One is your impedance and the other one is optical. And I think we have partly answered it there. Probably we can just move on to the next question.
Good. Fragmented red blood cells. How sensitive are and how good is the negative predictive value vis-a-vis with a smear review? Dr. Sitalakshmi.
Thank you for that question. I think we had an extensive discussion on this topic, and to answer this question very crisply, yes, assessment of fragmented reticulocyte cells on the hematology analyzer is a very sensitive parameter. How good is the negative predictive value versus smear review? Yes, it's another point that yesterday it was discussed. Negative predictive value is very good. So that means it's very sensitive, but specificity is a big question. And therefore, it's important to correlate it with smear in the clinical context, and because there are several other conditions where you can get fragmented red cells. So clinical context, smear review, and very importantly, it can use to follow up patients. Once you diagnose a patient with TTP, extent of fragmented reticulocyte, percentage and numbers to monitor following probably a plasma exchange. This is a useful parameter. That's something all of us should keep in mind. I hope I answered.
Very good. I have to add something to this topic because I was discussing during the ICSH meetings with Professor Gini and other people that has worked a lot in fragments. The important is, as you said, these parameters is very sensitive, but sometimes we are asking ourselves, is it specific? And I think we need to use the other parameters like the spherocytes. If we see spherocytes in the same blood smear, that will help the predicted value that are real schistocytes. And the other one, it will be the reticulocyte counting. The reticulocyte counting will also help us to assess that are real schistocytes. Moreover, when the persons that are in the laboratory in this moment, not always is the expert there to review it. I think these parameters have to be included together with the fragments to assess that are real fragments and not artifacts or broken red cells. Okay. Fourth question. Do you see a greater role of the optical RBC counts in the future? This is for Anil Handu. Maybe you have answered in your speech, but
Yeah, I mean,
here is the question.
Look, I think it's still an area where perhaps we have to work a little bit more because it's a parameter which was not previously available, in most of the analyses. It's come out in just about last few years. What we have observed in our setting with respect to optical RBCs, especially when you combine the information which is coming from the histograms, you are actually able to give far better diagnostic clues from the instrument itself, and classification of various subtypes of red blood cells are possible, especially based on the optical part of it, far better than what you get from histograms alone. So perhaps the work that we have already done has given us some indication that we're able to pick up the megaloblastics or dimorphics or the ones where there has been a transfusion and stuff like that. So all of them are actually being picked up in a much better manner. And of course, we all know about the fact that when you are looking at the reticulocyte channel per se, wherein the information is also coming on the retics part of it, when you combine all of them together, you are able to get far better information for indicating what kind of a disease are you dealing with respect to the red blood cell proliferation within the marrow. So it's a promising tool. I think probably a little more exploration from everybody would perhaps help. We are already on the job in our center as well.
Okay. What I have to add, maybe that as a summary of this talk, I want to finish with the previous one, so very briefly, that for me the important is to remind that hypochromia is not always that you have to administrate iron. It is important to know that many anemia of chronic disease have low iron, low transferrin saturation, but the ferritin, I found ferritins of 2,000, 3,000, 1,700 with iron overload. But this is important for me to explain that hypochromia measured with optical RBC needs also the ferritin to see, moreover, when the C-reactive protein or any inflammation marker is positive, to avoid iron overload. And that we go to the next topic, that is the unghosted cells. And Dr. Anil Handu, maybe you were talking about that?
I think somehow all the questions seem to be biased towards me only. I would rather direct this question to Dr. Suri and the rest of the team here.
When the companies do new parameters for certain disorders, like malaria, we know, all of us, that in some areas of the world there is PBEX that is more frequent, in some others is falciparum, and it is important for the companies to have all these false negative reported to the company, because today that when we are doing artificial intelligence and machine learning, it is important to have enough cases, not only of the different species of malaria, but also the different phases of the infection. It's not the same that the ring, that to have other forms of the parasite, and that is the important to collaborate the companies and the users, because with that I am sure that the flag for falciparum will be also very sensitive. And I pray and I ask the people, please share all the false negative for malaria, but also for blast, for any, because the machines can continuous learning as the Toyota way, the Kaizen, continuous improvement with the help of the customers.
Yeah, I think the only thing which I would like to add here is that please remember, when you will have a malaria flag which is getting highlighted by the instrument, and you have a high parasite density, you will have interference in your WBCs and your counts will be falsely elevated. So you have to be very cautious what you're reporting out as WBCs. Please don't blindly follow it, and the instrument actually does not flag it out to you that count has been taken out of the actual counted number of cells. Though there are some instruments which have that facility as well. But we need to be careful about the number of cells that we're giving in terms of the WBC counts. I think that was an important message which we need to make sure that everybody...
I'll just add, we don't have the infected RBC flag, we don't look, but we still, good old pseudo-eosinophilia works for us, for MP. The eosinophil plot goes, and so we use that as a surrogate marker.
Yeah, and I agree with Dr. Handu that the plots of every case are very important. I recommend all the labs to have like a poster with the plots of the different situations that we can find in the laboratory that are rare, like candidiasis, like interference of malaria in the eosinophil count that some technologies have, and also provide these cases to the companies in order that they can improve the algorithms to do the white blood cell differential in cases of parasites, fungi, bacteria, etc. Yes, very well point, Dr. Khandu. Okay, is the instrument-based reticulocyte count a reliable count? Dr. Sitalakshmi, please.
Yeah, to have a very crisp answer to this question, yes, instrument-based reticulocyte count is reliable. Enough of validation has been done, and most hematology analyzers give an accurate, reliable reticulocyte count. And of course, every lab has to have their own internal quality control protocols. We have to be alert about the flaggings, and whenever there is a flag, especially in the setting of clumping of red cells, or if there are giant platelets, we should verify manually to establish the correct reticulocyte count. But by and large, the reticulocyte count on the hematology analyzer is very reliable and accurate. And there are methods which uses both fluorescence and non-fluorescent dyes, and laboratories have to establish their own reference ranges which will add value to their interpretation. Any other comment, please?
I would just like to add that more than even accuracy, the automated count is more precise than the manual counting, primarily because of three reasons: the visual acuity of the pathologists, the variation in the field of the microscope, and last but not the least, the patience of the pathologist himself.
Very good. Yeah, absolutely, I agree. Good. We move to the next point. Are different hematology analyses comparable vis-a-vis the reticulocyte count? Dr. Sitalakshmi, again, the same similar question, but now comparing technologies.
Yeah, I think this was partly addressed in the previous question. Different hematology analyzers follow different methodologies. Some of them use the fluorescent dye, some of them use a non-fluorescent dye, but however, they are quite comparable, I would say, although there are reports to say that those which use the fluorescence method have a fairly false higher measurement, but as I mentioned, if the laboratories have their own reference ranges, and if they use the same hematology analyzer for follow-up, and then we would eliminate this difference to a certain extent. But to answer that question, yes, they are quite comparable.
I would just like to partly correct, ma'am. Fluorescent dyes are not false positive. They are just more sensitive, because there is nothing known as false fluorescence. Being an immunopathologist, either you see fluorescence or you don't see fluorescence. There is nothing known as a false fluorescence. And secondly, just another word of caution that the reference interval for each analyzer has to be ascertained differently, because there are different kinds of dyes, fluorescent, non-fluorescent, and also each company is using a different algorithm also. So blindly taking the biological reference interval of manual automated reticulocyte count and putting into your automated setting would not be a good idea.
Yeah, I think for me the important, as it was said here, is that every laboratory somehow review with few cases the reference values and also have a moving average of normals. From time to time, you collect some normal people and you review the reference values. But also for the different instruments, if the parameter is not calibrated, if you have 3 instruments from the same brand, also it's good to know that all the 3 instruments are giving the same type of results, and to duplicate or triplicate the samples between your instruments, because some of the companies have calibrators or controls for some of these parameters, but some of them not. And it's important to know that there are fixed cutoffs, like for aplastic severe anemia, that are 0.5, and it's important to review these cutoffs using a difference method that is fluorescence. Any other comment about this point? In this case, we go to the next one. How do you use reticulocyte hemoglobin equivalent and immature reticulocyte fraction in your daily practice? Dr. Swati Pai?
Actually, I don't use it. I make my clinician use it. Because I'm a laboratory physician, I would like to report it with every case from nephrology or from clinical hematology. But my success story is that I have successfully convinced the nephrologists to use it, especially when they are deciding on oral iron or intravenous iron or erythropoietin stimulating agents for their cases on dialysis or without dialysis. So we use it in nephrology for our CKD patients. We use it in rheumatology for anemia of chronic disease. This is in our hospital for the last 5 years. So, and as somebody said, immature reticulocyte fraction in BMT, it has been a failure for us. We have not been able to convince it is still the ANC and platelet. So functional iron deficiency, yes, we have been using reticulocyte hemoglobin equivalent, not so much the IRF because they're not really looking at how much IRF rises. So I can only tell you my experience, which is large because we are a 650 bedded hospital. So RET-HE in iron deficiency, functional iron deficiency, and in patients of CKD on or off dialysis, we are using very frequently. I mean, I have made the clinicians use it, but not in transplant settings at all.
Yes. Any other comments from the present experts? Because I want to add something. For me, IRF has a part of the engraftment after bone marrow stem cell transplantation, have an important role for ineffective erythropoiesis. When IRF is high and reticulocytes in absolute number and percentage are normal, that it's can show ineffective erythropoiesis, and you can expect to have megaloblastic anemia with B12 deficiency, an anemia of chronic disease, or myelodysplastic syndrome. And this combination of IRF and reticulocyte count is a useful parameter. And I repeat again, because for me it's crucial, many hospitals have hemodialysis patient with huge number of ferritins in the hemodialysis patient, is when you have a low reticulocyte hemoglobin, you have to decide to give iron or not due to ferritin, not only with evidence of functional iron deficiency, that is reticulocyte hemoglobin content. Ferritin is still a very good parameter to be combined with reticulocyte hemoglobin. And we go to the next one, the 10th. Yeah. What problems did you encounter with the newer parameter vis-a-vis standardization or not having a reference range or acceptability among the clinical fraternity? Dr. Swati Pai?
Yeah, you know, when you come to these CUBE meetings, you feel it's very easy to establish normal ranges. Everybody talks that our lab established normal range. But I've had problems establishing normal range because, for example, I think for the third CUBE, we came up with RET-HE, our range. So you have to get 100 samples. It's not easy in an institution like mine to get 100 normal samples without IRB clearance. That is the first step in big hospitals. You have to, whatever you establish, you want to do any study with any extra sample, you will not have, you're your own boss. You cannot use any sample for extra study without submitting, even if you're establishing normal ranges. So, you know, if you're doing it, yesterday Kunal evaluated this analyzer, it would not be so easy for me to analyze, to set up a machine, you know, just to analyze. So the first step comes in getting a clearance to use samples from the health check or from blood donors, you know, to establish a range. Second, when you establish RET-HE, it's a cost, at least 100 samples you're going to run. So I would put the onus on the manufacturer that help us establish, so, you know, we establish our range. But yes, it is mandatory that at least good laboratory practice that you establish your own range. So the difficulty is only in the clearance, but the fun part, I think the fourth CUBE when we talked about dysgranulopoiesis in CKD, that time we were looking at the Newt side scatter in normal patients. The difficulty is okay in the cost and getting the sanctions, but the fun part is the amount of information you get when you establish your own range. When we've already published it in ISLH journal, IJLH, when we noticed dysgranulopoiesis in CKD with low side scatter. That was a time we were just establishing our ranges. We didn't know where these patients were coming, who had low side scatter. So despite all the difficulties, you get a lot of information when you establish your own range and when you can tell the clinicians. Like yesterday, somebody said 33. Sukesh's range for Reticulocyte was 33. Ours is 27, 28. The information that you can generate, and you're your own boss then, that you've established your range, you found a lot of other findings which people haven't published. So yes, there are some difficulties, but in the end, I think it's worth establishing your own range.
Any other comment from the present?
Acceptability. Yes. So acceptability, I have a very important, my first-hand experience is not related to cell counters, but when I set up my MRD for myeloma and for AML, I told my clinicians, we work as a team, and I think all hematopathologists work very closely with their clinicians. So I told my clinician, I have set up my MRD for AML. So he told me, so do you want to tell me what should I do with your data that you've generated? Because I will still treat the patient the same way. So if you have a new parameter, the first thing is to tell your clinicians that there is such a new parameter. How will it help? Reticulocyte was not easy for us because we deal with clinical hematologists. For us, the first time we actually started dealing with nephrologists was during Reticulocyte. Earlier we had not, you see, every clinician has his protocol. When we talk of CKD has 5 grades. They don't do HB all the time just because we want to see Reticulocyte. They are not going to do hemoglobin. They have a day when they will do hemoglobin. If you see your records, you go back, a dialysis patient doesn't get his hemoglobin done all the time. So to tell them that now is the time to do Reticulocyte, it takes time, but I think it's all about communicating to your clinicians. So we have our own, because I work in a hospital setup, our own CMEs, we send out circulars, we send out publications, and we convince them. So when we started IPF, for example, we started reporting IPF. One of our gastroenterologists came and told me, why have you written the textbook of Harrison down? IPF is so-and-so about. So once you have communicated, it is difficult, but it all becomes easy once they accept it. Acceptance comes, but you have to give scientific evidence along with the publications.
So can I just add a point here? And I would actually want to ask, and I'll throw it open to everyone. The question when it was framed was actually one part of it, what Madam has already explained. I'm sure, did any one of you ever try to get these parameters accredited during your NABL assessment? Did any one of you try doing it?
Yes.
And did you face a problem with the assessor who came and who told you, no, he will not want to accredit it because you don't have a traceability?
No.
And if it happened, what did you do?
No. So when we first started, I think when XN came, we were one of the earliest XN users. We started giving IPF. And during that assessment, they said that the AIMS doesn't have IPF. So you cannot report your IPF. So it does happen with during assessment. So they said you cannot, then we made a separate code. IPF, platelet IPF, this was I think in 2010 or something. But it's very difficult to have a new parameter as part of, even Reticulocyte. Now we call it Reticulocyte and parameters. We don't call it just, what CHR or Reticulocyte. It is difficult to give it in a report format. You have to map it with the IT. It is also a billable item. So it's difficult to get it into the report.
Yeah, any other comments anybody has with respect to this?
NABL is a challenge.
Oh, because there was a question yesterday, somebody is asking us to, I think Dr. Gupta, I'm not sure whether he's here, so he's asking that, why don't we just talk to NABL and tell him that, tell them that we want to add these parameters and then they should allow this to happen. Look, I think it's not NABL which has to do it. It's us who have to start accepting these parameters, that they are there and they are robust and they are good enough for us to be putting it in the report, validating in our own centers. And at least when you have the validation data, you are able to put them in the report, as simple as that. When you put immunohistochemistry, a lot of these immunohistochemistry markers are IVD, but you still approve, RUO, and you still get them onto the report and you say it's whatever CDX, YZ positive, and then it's because of that it's this tumor. And similar story on a flow cytometry platform, and who will forget the NGS? Which NGS report is actually not a research report at the moment? None of them are IVD approved kits. Yet you're giving the results out to the patient, and the patient is being actually treated with all these monoclonal antibodies, right? So why be discriminatory to a parameter which is so robust and coming out from an analyzer on a regular basis? You run the sample in the machine 10 times, it will give you similar result. You don't want to believe it, but on the other hand, you do an IHC and some different guy does an IHC, you get a negative result, and yet you're wanting to call that RUO IHC very good, and not a parameter which is getting repeatedly produced. So there seems to be some dichotomy, and I agree with a lot of people who were discussing this with me yesterday in the evening as to why are we discriminatory towards these parameters. Why? Because I think it's coming out easily, you know. If it was somebody spending the whole day putting up that thing with a pipette and then tilting it, turning it, putting it in a pressure cooker, getting it out of there, and then putting a cover slip and then seeing, and saying, oh my God, I'm looking at such a beautiful crisp staining and now it's positive, I think probably we would take it more. This is what I feel. I think what is expected, we should ideally be expected to do a good validation. Yes, Dr. Mishra, you want to say something there?
Yeah. I want to say something too, please, Dr. Handu.
Yes, please.
Yes. I want to say that for me, there is an important point. Hematology, we have been too much perfectionist. And Dr. Handu said, in chemistry, the values of ferritin, PSA, many of the parameters are very variable between companies and between even the same hospital with different instruments. And the thing is, we have to use these parameters for sure. But what we have to do, as we recommend today, to use the calibrator or the standard that the company give us, but also to see the moving average, to compare from time to time in the quality control, to run one patient sample in the 2 or 3 instruments we have, because the majority of the hospitals have 2 or 3 hematology instruments now, because the big overload of samples. And that is an important experiment to do, that all our instruments are giving the same result. And also from time to time to analyze samples with another method to confirm. And with that, I think we have to report these parameters because, look, in hematology, we have had for 30, 40 years always the same parameters. Why? In chemistry, in immunochemistry, they have released practically every year a new parameter, BMP, PSA, etc., free PSA, and not in hematology. And that is for me the important. We have to set up some standards and some look for the patients, controls and the patients as we do for the MPV, but to use these parameters, because if not, we are in the prehistoric age in hematology.
Yes, I think I heard what Swati spoke. You see, the acceptability of any laboratory result is only acceptable if it is actionable. Until unless the result is actionable, I don't think any clinician accepts it. There are 2 types of clinicians. One cohort of clinicians will read themselves, update themselves, and apply themselves to the newer things. The second cohort of clinicians will wait for the pharmaceutical representative to arrive at them and say that, sir, this drug has come. It is to be given at 10 milligram BD dose and toxicities of this. And if there is toxicity, take him off for 2 weeks and restart at a lower dose. That is the second cohort of clinician. He is not bothered what Swati is giving, the newer parameter, the newer thing, MRD in acute myeloid leukemia, 0.001 or 0.01, same thing happened. Very astute clinical hematologist in a hospital said, Deepak, you have said that the cutoff for AML MRD is 0.1%. What do I do with this result? I don't treat the numbers, I treat the patient. I said, sir, this is now a clinically relevant thing which is current. Most institutions are doing AML MRD. So he will ask for literature, trials. I said, sir, UK MRC AML trial has considered AML MRD as a treatment time point. So I think whenever new such parameters come, it is our responsibility to make people wiser as well. Suppose you have RET-HE, if your RET-HE is elevated or RET-HE improves to some treatment, whether in some disease it decreases, I think they have to be primed. Standardization is one aspect, but its acceptability as a new. How many clinicians read your 7-part differential parameters? They don't read. So in the HMS, when you read the parameters, you have to pick and choose which one will be beneficial for the clinician. You just don't randomly put the whole thing into the HMS. So I think we have to be discreet, discerning, and we have to educate the clinicians.
Let me make another comment, final, that I think this slide is one of the more important of this series, is that the FDA CAD parameter, but there is research, but there is an intermediate step that is laboratory use only parameter. What's that? When I said that you have high IRF and normal reticulocytes, yes, we can maybe have the approval of FDA, but try that the clinicians are using that for the clinical diagnosis. Will be difficult to train all our clinicians about that. But we can do is when we have a rule in our laboratory informatization system that when a high IRF with normal retics happen, we are going to review the case and to see other parameters to check if it's a megaloblastic anemia, if it's a MDS, and we are going to report not this combination of IRF and reticulocyte count, but the next test or the next examination, looking at blood smear, looking IRF, looking other parameters to finally get an idea what the patient has. And finally, we will make a comment in the laboratory report. But that is a concept I would like to insist. We can begin to use the concept of laboratory use only parameters, not reported maybe or reported, but we know that the clinicians will ignore it, except some of the experts, but we can make reflex testing, other tests like blood smear, like IRF, like whatever, hemoglobin, chromatography, etc., to report finally this approved parameter.
I think there is
Hi.
a comment. Yeah.
Can I add? I'm in full agreement with Ramon as well as Dr. Mishra that the clinicians, it does not make benefit or matter the values and the numerical things that are printed out by the machines. I think it is us that we have to give an impression. We have to give an impression on what does all that parameter mean for that patient, which will indirectly affect the clinician. So thank you, Dr. Ramon, for bringing out this, that the impression has to be there of all the data that is being generated by these machines, which is super data, like Dr. Mishra said. What is the use of giving RET-HE and all these values if you're not interpreting in the light of that patient? Very important. Thank you.
Dr. Ramon, I think this will be the last question for the day.
Okay.
And, yeah, I would like to you to give a concluding statement for the panel discussion and thank all the panelists.
I have to say something. I have been in many meetings because they are inviting me from Middle East, from America, in Europe, and I have to say that from these meetings are happening, the level of the Indian laboratory community expertise is one of the highest in the world. I think you have to feel proud of this initiative that you are doing to meet together, to do research, to improve hematology, because as I said, in many countries, only they have the same 30 parameters that were 20 years ago and no research. And for me, India is one of the examples how the laboratory hematology has to be. And I am very proud that you count with me every time and to be able to participate with you, because the level of these conferences was really very high, and I am very proud to be part of you in your group.
Thank you. Thank you very much. That's really encouraging and nice. And we look forward to interacting with you again next year on a new platform of Cube.
So, I would like to thank all the panelists and our moderator, Dr. Ramon Simon. Moving ahead with the next session, next talk, may I invite the next chairperson for this talk, Dr. Prabhu Meghnathan, Director, Hybrinomics. Thank you.
Thank you, Shama, for giving me the opportunity. I'd like to call upon the next speaker, Anuja Chopra, Managing Director of Precision Diagnostics, Ahmedabad. Should be giving us a talk on macrocytic RBCs, thinking beyond megaloblastic anemia.
Hello friends, I'm Dr. Anuja Chopra. I'm from Precision Diagnostics, Ahmedabad. First of all, my sincere apologies for not being present here physically, but it was really due to some unavoidable circumstances that I'm not able to make it. However, I'll definitely proceed with the topic that we had agreed upon, that is macrocytic RBCs, thinking beyond megaloblastic anemias. Crops to our mind is large RBCs, few oval macrocytes, and hypersegmented neutrophils, classically representing the megaloblastic anemia. But the story does not stop there. So, what exactly is macrocytosis? Macrocytosis literally means having larger RBCs. So, it is generally defined as a mean corpuscular volume, or MCV, greater than 100 femtoliters. So, this is how it would normally look like in a normal smear and a macrocytic picture. But we need to evaluate this macrocytosis even in the absence of anemia, as this may be the first clue to an underlying pathology. Macrocytosis without megaloblastosis has numerous causes. The first one being the physiological causes, that is pregnancy, newborns, and infants. Macrocytosis without anemia may sometimes be seen as a normal variant found among some members of the family, which suggests a genetic predisposition. Then cold agglutinins is an artifactual macrocytosis. Hyperglycemia, leukocytosis, reticulocytosis, delayed sample processing, which causes a falsely elevated MCV, a liver disease, alcoholism, myxedema, respiratory failure, and myeloproliferative and myelodysplastic syndromes. So how do we go about evaluating macrocytosis? We need a complete medical history, red cell parameters, and a detailed peripheral smear examination. These are the simple and inexpensive tools which help in identifying the underlying cause of macrocytosis, particularly in resource-limited settings like ours. So on physical examination, the first thing that we notice is conjunctival pallor, noted mainly in patients having severe anemia. Glossitis usually represents macrocytosis, resulting from B12 or folate or deficiency of both the elements. Then you have tachycardia and flow murmurs, mainly in severe anemia. You have splenomegaly if there is macrocytosis due to hemolysis, infiltrative disorders, or neoplasms. Then you have jaundice, suggesting liver disease or hemolysis. Neurological disorders such as ataxia, loss of posterior column sensations, loss of deep tendon reflexes, suggesting thiamine deficiency. Now, the most common cause that we come across for macrocytosis is alcoholism. Now, in alcoholism, the macrocytic anemia is not necessarily due to B12 deficiency or folate deficiency. There are a lot of other reasons why we have macrocytic anemia in alcoholism. One being liver disease, marrow suppression due to the direct toxic effects of alcohol on the marrow. Then hemolysis occurring in the bone marrow, in the peripheral blood. Then there is stomatocytosis, spur cells, hypersplenism, and you also have microcytic anemias due to GI bleed. So what are the stages of anemia that occur in alcoholics? First is a stage of a negative vitamin balance where because of the reduced dietary intake and increased ingestions of alcohol, there is a sharp fall in the serum folic acid with no abnormality visible in erythropoiesis. Then the next step is the sideroblastic conversion, which occurs soon after the megaloblastic change. Could be due to pyridoxine deficiency or maybe due to an intracellular enzyme defect. Then there is a phase of early resolution wherein a recovery stage comes up with disappearance of megaloblastic change but persistence of the ring sideroblasts. That makes marrow interpretation difficult. And then you have the stage of late resolution in which there is marrow erythroid hyperplasia with reticulocytosis simulating a hemolytic state. Now, what are the types of anemia that we are coming across? One is macrocytic anemia due to abnormal liver function, macrocytosis associated with increased membrane cholesterol and phospholipids in normal ratio, folic acid deficiency, stimulated erythropoiesis with hemolysis and reticulocytosis. Normocytic anemia occurring due to hemolysis due to marked increase in the membrane cholesterol, that is the spur cells. Then you have hypersplenism and bone marrow hypoproliferation due to the direct toxic effects. Microcytic anemia can occur due to GI bleed occurring because of the liver disease and alcohol. Now, these are the peripheral smear findings that we come across. You have macrocytes, macroovalocytes, hypersegmented neutrophils, suggesting a megaloblastic disease. Then you have stomatocytes. These are the spur cells and the polychromatophils. Then reticulocytosis also confuses the picture and gives a false macrocytosis. This just indicates an increased RBC production. Corrected retic count here is more than 2% and the reticulocyte production index is more than 3. Now, the causes of reticulocytosis can be acute blood loss, acute hemolytic anemias, hemoglobinopathies such as sickle cell anemia or thalassemia major, and post-treatment bone marrow response, particularly when you give an iron supplementation, folate supplementation, or a B12 supplementation. Now, some interesting facts about macrocytic anemias are that an MCV of more than 100 with an increased RDW, macroovalocytes, and hypersegmented neutrophils suggests a megaloblastic disorder. Now, megaloblastic processes are characterized by the presence of macroovalocytes and hypersegmented neutrophils. This is a very, very classical feature which we come across in megaloblastic anemias. However, you may not always find hypersegmented neutrophils, particularly when there is a marked shift to left or if there is a severe neutropenia. Oval macrocytes are reported to be more sensitive but somewhat less specific than the neutrophil hypersegmentation in predicting the megaloblastic changes. Non-megaloblastic conditions display more uniformly round macrocytes and normal RDW. Round macrocytes are more commonly seen in alcoholism, and round target appearing macrocytes are characteristic of liver disease such as hepatitis and obstructive jaundice. There are some interesting facts that we need to know about macrocytic anemias. An MCV of more than 100 femtoliters and increased RDW with macroovalocytes and hypersegmented neutrophils are characteristic of a megaloblastic disorder. And these are usually seen in most of the cases, but hypersegmented neutrophils may be absent when there is a marked shift to left or if there is a severe neutropenia. Macroovalocytes are reported to be more sensitive but less specific than hypersegmentation in predicting the marrow megaloblastic changes. Non-megaloblastic conditions display uniformly round macrocytes with a normal RDW. Round macrocytes are commonly seen in alcoholism, and round target-like macrocytes are characteristic of liver disease such as hepatitis and obstructive jaundice. A mean RDW of 21.6 was noted in a study against in megaloblastic cases against the RDW of 13.7 only in non-megaloblastic conditions, indicating that RDW is significantly higher in megaloblastic cases. Increased RDW with macrocytic anemia is seen in megaloblastic anemias, myelodysplastic syndromes, and chemotherapy. In liver disease and aplastic anemias, RDW is normal or very mildly increased. A combination of low red cell count, high RDW, and a normal thrombocyte count is highly sensitive in detecting B12 or folate deficiency. Though not specific for one condition, an elevated MCV of more than 100 femtoliters is a useful parameter directing further investigations, which can ultimately lead to a definitive diagnosis in 75% of the cases. It may be the only indicator of vitamin deficiency and alcoholism, and refractory unexplained macrocytosis may be an early sign of MDS or smoldering leukemia. Now, when we come across mechanisms of macrocytosis, they are different with different etiology. For example, in B12 and folate deficiencies, it is due to a defective nuclear maturation, which leads to the hemoglobin synthesis preceding the nuclear maturation, thereby resulting in larger than normal red cells. In alcoholism, it is mainly due to the direct toxic effects of alcohol. In MDS, it is due to dysplastic changes. Hepatobiliary disease and mixed edema, it is due to excess of lipids in the red cell membrane. Drug-induced, in case of reverse transcriptase inhibitors, is due to interference with DNA production. In cold agglutinin, it is actually an artifactual thing because of the erythrocyte clumping, as the clumps are counted as single erythrocytes. In hyperglycemia, the intracellular hyperosmolality causes the cells to swell in the solution. And in case of marked leukocytosis, the leukocytes are counted as red cells. And that is why there is an increase, there is a false increase in MCV. Now, how do we approach a case of macrocytic anemia? If you have a case, a patient presenting with an MCV of more than 100, first rule out drug exposure. Once that is ruled out, have a good look at the peripheral smear and the reticulocyte count. If the reticulocyte count is very high, evaluate for hemolysis or look for any site of bleeding. If there are no macrocytes on blood smear, consider a laboratory error such as a cold agglutinin, hyperglycemia, or leukocytosis. If you see oval macrocytes, do a serum B12 and folate level and evaluate. If you get a normal B12 folate level, do a bone marrow aspirate and biopsy with cytogenetics. Most likely, you will come across a case of myelodysplasia. If it is low, we need to evaluate for the cause of megaloblastic anemia. And if you find round macrocytes on smear, do an LFT because it is most likely to be due to liver disorder. Now, how do we go about approaching megaloblastic features? If you find megaloblastic features on peripheral smear, do an RC or a reticulocyte count. Now, if it is raised, review the B12 levels. If it is less than 100, it is clear-cut B12 deficiency. If B12 is more than 100 and but less than 400, do the methyl malonic acid and homocysteine levels. Now, both MMA and homocysteine levels are elevated, clear-cut B12 deficiency. If MMA is high and normal homocysteine levels, again, most likely to be due to B12 deficiency. Both MMA and homocysteine are normal, do a bone marrow evaluation. If MMA is normal and homocysteine is elevated, most likely due to folate deficiency. B12 is more than 400, do a folate test. A low RBC folate indicates folate deficiency. Normal RBC folate, do a bone marrow. Now let's take a few cases so that what we have just seen becomes clearer. This is the case wherein we had a CBC finding of hemoglobin of 17.7, WBC count of 16.7, and MCV of 105, and platelet count was normal. So this was the smear that we had, a crowded smear with macrocytic RBCs, occasional normoblasts on smear, and looking at the age of the patient, we found out that this was a newborn smear. Then the second is a case of a 54-year-old male presenting with a history of hypertension, 1 month history of intermittent chest pain, non-productive cough, dyspnea on exertion, and a 22-pound weight loss over 4 months. Complete blood counts revealed a macrocytic anemia with an MCV of 108. LDH, bilirubin, B12, and red cell folate levels were normal. Coombs test was negative. Peripheral smear showed some dysplastic changes in all hematopoietic lineages, including hypogranulation, hypersegmentation of neutrophils, and rare teardrop cells. So this was the peripheral smear that we had. We had macrocytic RBCs, few teardrop cells here and there. Then the neutrophils were dysplastic. See, this is the pseudo-Pelger-Hue anomaly, the non-segmented neutrophils, bilobe neutrophils, and the hypogranular neutrophils.
Madam.
Yeah. Hello. Bollier. Hello. Shama, this thing is cracking.
Hello.
Hello. Yeah.
Your internet stable. Your internet connection is unstable.
Just let me change my. Better here?
पेज अप करिए. No, before this. This. After this.
This one, no?
This one, peripheral smear.
This was the peripheral smear of our patient, wherein we had here and there few teardrop cells with lot of macrocytic RBCs, dysplastic neutrophils with a pseudo-Pelger-Hue anomaly, non-segmented neutrophils, bilobe neutrophils, and hypogranular neutrophils. Bone marrow was done for this patient, and this was the aspirate. We had erythroid hyperplasia with mild increase in blasts. The blast percentage that we found was around 8%. We had, these are the binucleate megaloblasts that we found. Then we also had megaloblasts with dysplastic erythroblasts with abnormal budding. You can see the abnormal budding here. The megakaryocytes were small with non-lobated or hypolobated nuclei. This was the bone marrow biopsy of the same patient, wherein we had a hypercellular marrow with tri-lineage erythropoiesis and erythroid hyperplasia, which is evident in the slides. A flow cytometric study was performed on the bone marrow aspirate, and it showed expression of CD34, 38, and weak CD45 and CD117, and negative for the B cell and T cell markers. The CD34 positive blasts represented around 13% of all the bone marrow nucleated cells, and in addition there were megakaryocytes of varying sizes highlighted by the CD61 stain. The bone marrow biopsy sections revealed a markedly hypercellular marrow with marked erythroid proliferation, and there was loss of 7q on karyotype in 20 out of 20 metaphases. Reticulin stain showed mild to moderate myelofibrosis, and the diagnosis of myelodysplastic syndrome with excess blasts was made. The third is a case of a 58-year-old male presenting with history of breathlessness on exertion since 4 days, no previous respiratory history, and on examination, the patient was afebrile, pallor was present, and respiratory rate was 22 per minute. ECG was done at a peripheral center, and that was normal. There was cervical, axillary, and inguinal lymphadenopathy with mild hepatosplenomegaly. CBC showed a hemoglobin of 5.2 with an MCV of 106. WBC count of 9,800 and platelet count of only 9,000. PS at the peripheral center reported as macrocytic anemia with thrombocytopenia and reactive lymphocytes. Patient had a spike of fever soon after admission. A bone marrow examination was requested for cause evaluation of the anemia with a possible diagnosis of an underlying lymphoma or leukemia. Now, these were the peripheral blood findings that we saw when we took a bone marrow. There was clumping of blood that was noted at room temperature, and this disappeared on warming the sample at 37 degrees in a water bath. Peripheral smear and CBC findings, hemoglobin of 4.6 was found with MCV of 156. An MCH of 66, MCHC of 52.6, RDW of 54.5. WBC count was 14,000, platelet count was only 7,000. PS showed RBC aggregates with few spherocytes, 8 normoblasts per 100 WBCs. Marked polychromasia with few spherocytes was noted. See, this is the marked reticulocytosis that we saw. On bone marrow, there was marked erythroid hyperplasia. Other investigations that we did, direct Coombs test was strong positive, ICT was negative, but autocontrol was strong positive. A cold agglutinin antibody was done and it was strong positive, more than 1016, 1 in 1016. So a diagnosis of autoimmune hemolytic anemia was made and cause evaluation was requested. Now, in view of the cold agglutinins that we found, with short history of fever and thrombocytopenia, a possible viral etiology was suggested. EBV panel and PCR for EBV was ordered and it was found to be positive. So the final diagnosis was cold agglutinin disease secondary to EBV infection. Thank you so much for being a patient audience.
Thank you, Dr. Anuja Chopra. Thank you, Dr. Anuja Chopra, for such a wonderful presentation. There's a question in the chat. Have you come out with your own cutoff for MCV and RDW in case of microcytosis?
Like mostly if it is, we do see it. You definitely, I mean, it with the clinical picture. Actually, I have a direct one-to-one and I'm able to get most of it. It's very helpful, the adding that we normally find megaloblastics are 18, 20, 21. In the, of course, we are in Gujarat, so sources are very few that we come across. The RDW is much lower, actually normal. Say that's what we've seen. But of course, with alcoholism is. Hello.
Any other questions? No, we can't see. So, ma'am, there are no other questions. So, thank you for your participation as a speaker. And really apologize for the time constraint because there was a lag in the program and we had to prolong the program, and that is why we kept all the online sessions later. Thank you, ma'am. Thank
No
you.
worries.
Thank you so much.
Yeah.
Sorry. May I request Dr. Ramon Simon now to enlighten us with his talk on new hematological tools for the diagnostics of megaloblastic anemia due to B12 deficiency, not only red cells but also leukocytes. Over to you, Dr. Ramon.
Hello, I am very happy to be again with my colleagues from India in this CUBE meeting 2022. I have prepared a presentation that I am going to share with you. As you know, this time my talk is about new hematological tools for the diagnostic of megaloblastic anemia due to B12 deficiency, not only red cells, but also leukocytes. This is a normal case analyzed with the instrument Mindray, in that you can see that there are the classical parameters, the differential, the RDW, but also there are new parameters like IRF, LFR, MFR, etc., and some other parameters that we are going to see now here, that reticulocyte index, mean reticulocyte volume, microcytes in percentage in absolute macrocytes, etc., but also cell population data about information about the leukocytes. And here you have an example of a normal case with these results. But now we are going to talk about what other tools we have for the diagnosis of megaloblastic anemia. And one of them is cell population data. Here you have the reference values calculated in Italy about the reference values of these parameters. And as you can see, is the morphology of the leukocytes, automated morphology, site scatter, fluorescence, size, for the main populations of leukocytes. This is an example of a report of my instrument with this cell population data, that the same that we have for the MCV and for the platelets, MPV, MCV, FDW, we have the same for the leukocytes nowadays. This is an example just published by Dr. Boro, how these parameters, as you can see here, the cell population data of the leukocytes and different normal and leukemias, chronic leukemias, multiple myelomas, sepsis, viral infections. Here you have in high, in red, in bold, red, very high, low and very low, and bold, blue. And you can see that the pattern is different for the majority of the hematological disorders or the infections, the viral infection from the septic infection, the pattern is absolutely different. And that is really something that we need to explore in the next years. What is that? Look, this is the classification in the CUBE of the leukocytes using 3 technologies for Mindray. And of course, the same that you have the histogram for this volume, you can have the histogram for the site scatter or the fluorescence. This is the monocyte Z is the monocyte size, the mean monocyte volume. And here, the application for COVID, the application for megaloblastic anemia that we are going to see now. By the way, I was the first author presenting this information that was useful for megaloblastic anemia. And here you can see an example. Of course, these monocytes are not the same. This is big and this is normal. And that is the importance. Why that, and in which diseases can be useful that. The same with neutrophil size. In this case will be the neutrophils, and again also has been described by me and now other authors from India, that the neutrophil size is also important for the B12 deficiency, and the more important is not interfered by iron deficiency when the deficiency is combined. Here you can see an example of the size and the segmentation of a neutrophil, normal and hypersegmented, okay? To see that today we have parameters to see that also. This is bigger. And the neutrophil X is to see the complexity of the nucleus or the complexity of the cytoplasm, if it's normal granulated or degranulated. And there are several articles showing the benefit of these parameters. As you can see, with the neutrophil site scatter, the laser refracts in the particles that are inside the cell, and these cells will have different neutrophil X. And these cells also will have different neutrophil X, as we will see today in our studies. For this reason, the hypersegmented neutrophil also have different site scatter, and that can be used for helping for the diagnosis of the different disorders. Let me begin with a normal case here, with a normal cell population data. Okay, here a female with the same, with a normal. And now we will see anemia. This is the classification of the WHO about anemia. And as you can see, the majority of the anemias, 54%, 64% really are iron deficiency anemia and anemia of chronic disease. But of course, it's not that's something that we can ignore. The megaloblastic anemia that is in this part of the cake, 12% of the anemias. And here we will see which parameters are useful for megaloblastic anemia. For sure, when it's a pure megaloblastic anemia due to B12 deficiency or due to folate, the MCV is really important. As we will see now, it's working very well. But it's always like that? We will see. The MCV will be normal or high, because can be normal. And today, because many of the patients with B12 deficiency are elder, we cannot ignore that a patient can have a B12 deficiency just because the MCV is normal. And as we will see afterwards, even when it's low. There is an important specific pattern today with the new parameters. What is called ineffective erythropoiesis that we know that exists in megaloblastic anemia. We can see that with the reticulocyte parameters. Interesting that the IRF, the immature reticulocyte fraction, is high, but with normal retics in percentage and absolute number. And that is really important combination that also can be useful for detecting megaloblastic anemia. And now we are going to see some examples. This is a normal case. This is a case with a megaloblastic anemia from Dr. Hiren Danani. And here in the study we did with Dr. Danani that is accepted for the ISLH meeting, yes, I will just mention that here you can see the anemia of chronic disease, utilizing one of the new parameters, the macrocytes in percentage, big red cells in percentage. You can see that the B12 deficiency, analyzing 35 cases, is absolutely different from anemia of chronic disease and, of course, from normal. The number of macrocytes is a new parameter. In percentage is really very useful, and we can use that. But you can see also that the monocyte fluorescence is different. When B12 deficiency is much more higher, the fluorescence of the monocytes than in the iron deficiency anemia, that in anemia of chronic disease, or than in the normals. Interesting to MPV, mean platelet volume, with a statistical significance that is in the normals was 9.1, and in the B12 deficiency also platelets are bigger, 10.3. Neutrophil X, the neutrophil complexity that the nucleus hypersegmented can affect that, you can see is much higher in the B12 deficiency, 466, than in the normal 348 or the anemia of chronic disease or the iron deficiency. And finally, neutrophil Z, the neutrophil size, again, is higher in B12 deficiency than in anemia of chronic disease than in normal cases. And here you can see the same with the graphs. And the statistically significantly difference, analyzing 35 cases of B12 deficiency compared with anemia of chronic disease, with other non-monocytic and macrocytic anemias with no B12 deficiency, normals, and for this reason, compared with a set of a lot of anemias, you can see how the monocyte fluorescence is much higher than in the rest of anemias that were studied in this study. Here, the neutrophil size, the same. You can see that the B12 deficiency, not only the red cells are bigger, also the neutrophils are bigger, and statistically very significant with the P less than 0.001, comparing these anemias with a set of multiple anemias. The same MCV for sure, but as you can see, there are some other cases with high MCV. It's very good for sure, but there are some coincidences here for MCV. Monocyte Z, the monocyte size, also it's very important. You can see the area under the curve is 0.764, but the more important parameters are MCV, are neutrophil size, and MPV. As you can see, the area under the curve shows as closer to 1 is as much better, and the best ones is monocyte fluorescence, neutrophil fluorescence, neutrophil size, and mean platelet volume. Platelets are also important. Here you can see the ROC curve of MCV, fantastic. The MCH is also a very important parameter for B12 deficiency. The MAC percentage, today we have the percentage of macrocytes and the MAC percentage of an absolute number of macrocytes, big red cells. RDWSD has shown a very good efficiency comparing this 35 anemia B12 deficiency with the negative group of 700 anemias, including anemia of chronic disease, iron deficiency, etc. Neutrophil Z, as I said, very significant with a very good area under the curve, 0.945. Neutrophil fluorescence, the same, monocyte fluorescence. And monocyte complexity also was different. Here you have the summary of the different parameters with the different sensitivity and specificity and area under the curve. And what about platelets, as I said, are also bigger in B12 deficiency? Yes, are bigger and statistically significantly bigger with a P less than 0.001, comparing 35 B12 deficiencies with 740 anemias from different types. And this is the summary for megaloblastic anemia, as you can see, and you can see the cutoffs. And you can make a photo from your cell phone or make a print screen from your, because that is the important conclusion. The macrocyte count, the cutoff was 11.7%, and with a sensitivity of 100%, a specificity of 95%. RDWSD with a cutoff of 54.4, sensitivity again 100%, specificity near 95%. MCH 37.8. with a sensitivity of 86, specificity of 90, near 99 is one of the best specificities. You can see the specificity is one of the highest. Sensitivity, not so much, but MCH at specificity. MPV, the sensitivity 71%, specificity 66. And here you can see the cell population data, the leukocytes, size, complexity, etc., also with very good specificity and sometimes sensitivity. Here, the neutrophil X is very specific. That is, the neutrophil complexity, I think, is correlated with hypersegmentation. But what happened with the combined megaloblastic anemia with iron deficiency? Here, I have cases that will be presented during this Acute meeting, but with the permission of Dr. Ranjana Havaldar from Sampurna Sodani Hospital, we can see here an anemia with 78.6 femtoliters of MCV. Is that an iron deficiency? Sorry, is that an iron deficiency or what else? Look, the B12 was 74, and that is not just an iron deficiency, that it is, but it's also a B12 deficiency. And here the MCV will not be very helpful. But here you can see that in this case that the MCV is not so useful, okay? Because as you can see, there are big red cells, but there are also small red cells because it's a combined deficiency. There are an increase of the macrocytes, but it's an increase also of the microcytes. And here you can see what I said. Here is one of these cases with combined deficiency. As you can see, the percentage of macrocytes is high, 20%, but also the percentage of micro and macro. And that is the important. When you see both increased, you have to check ferritin together with B12 deficiency. And here, in this case, you can see that the microcytes in 0.7 in absolute number, in percentage, 20%, but also a macrocytosis with a 5% of macrocytes. Another case with B12 135, this is a little higher, but it's still for B12 deficiency, and again the same. The MCV was 69, microcytic anemia, and this is a B12 deficiency, and that is amazing. Okay, and here is the summary of these two cases compared with the normal. As you can see, the IRF was very high in these cases with combined B12 deficiency, and the reticulocyte count was low, a little lower than normal, and that is important. High IRF together with a reticulocyte count that is low. As we finish in this slide, in that you can see the pattern of the normals and B12 deficiency in the cases when we compare with this combined deficiency, that is iron deficiency with B12 deficiency. And the MCV in these cases was low. Summary of the combined megaloblastic anemia with iron deficiency. According to several authors, from 50 to 66% of all B12 deficiencies have normal or even low MCV. For this reason, we need to think about that, not only in this possibility in our lab, in our laboratory. In combined anemias with two or more deficiencies, we need to use both the percentage and absolute number of the microcytes, small red cells, and macrocytes, big red cells. And that is the message from this, one of the messages from this talk. But also we need to use the cell population data. In combined anemias, we need to use the leukocyte cell population data to be able to suspect B12 deficiency, because the neutrophils will be bigger, the monocytes will have higher fluorescence, and the neutrophil will have higher complexity, higher site scatter, the neutrophil X. And that is the important and we can create rules using these parameters in our validation system that can be done automatically in the case of anemia. To check for these parameters, we don't need to remember the cutoffs. We only need to double check the reference values of these cell population data in our instruments, and to create a rule that will flag us for possible neutrophil macrocytosis, possible neutrophil high complexity cells, and that will obligate us to see the blood smear, and if it's compatible with B12 deficiency, for sure, recommend the doctor to order a B12 determination to confirm that not only is an iron deficiency, it's also a B12 deficiency. Thank you so much for your attention. This is a lymphocyte from a young teenager with infectious mononucleosis, the Epstein-Barr virus infection, and in the microscope have exactly this, with no any Photoshop, this beautiful behavior of a heart. Thank you so much, and I hope to see you soon in India. Bye.
Thank you, Dr. Ramon. Thank you very much for your informative session. I think there are no queries now. So we move on to the next lecture by Dr. Ranjana Havaldar. Welcome, Dr. Ranjana Havaldar. Dr. Ranjana Havaldar is the head laboratory, Sudani Labs, and she will acquaint us with a study she has done in her lab on megaloblastic anemia.
Good morning, everyone. I'm thankful to Mindray India and Dr. Anil Handu and Dr. Ramon Simon Lopez for giving me this opportunity to present this basic research on the study of new Mindray reticulocyte parameters in the differential diagnosis of anemia in front of the August gathering. My topic is the study of new Mindray reticulocyte parameters in the differential diagnosis of anemia. And this is the first basic research in our laboratory. This study will be continued forward, but I am presenting the basic findings which we have got from this study. As we know, the data from WHO says that 37% of the anemic patients are iron deficient, 27% are due to anemia of chronic disease, 12% are due to ineffective erythropoiesis like megaloblastic anemia, refractory anemia, and thalassemia. 10% constitute the hemolytic anemia, and 9% are due to chronic renal failure and endocrine disorders, and 5% constitute due to aplasia. The most common causes of anemia are due to nutritional deficiencies like iron deficiency, folate deficiency, vitamin B12, and Other important causes of anemia are hemoglobinopathies and infectious diseases such as malaria, tuberculosis, HIV, and parasitic infection. According to the World Health Organization, anemia is defined as hemoglobin levels less than 12 gram per dl in women and less than 13 gram per dl in men. However, normal hemoglobin distribution varies not only with sex but also with ethnicity and physiological status. This is a prospective study, but initially we have studied 30 anemic patients and 20 patients with normal hemoglobin as preliminary data. We studied the CBC and reticulocyte parameters and compared it with normal hemoglobin patients. Other biochemical parameters were taken into account like iron, CRBC, ferritin, vitamin B12, folic acid, LDH to differentiate between the different anemias. The independent sample t-test was used for analysis for parametric continued variables and they were presented as a mean as well as standard deviation. A p-value of less than 0.05 was considered statistically significant. As we know, diagnosis of anemia, firstly we do a CBC in which we take into account the RBC count, hematocrit, hemoglobin, NCD, MCH, MCHC and red cell distribution width. Then we proceed to the reticulocyte count in which classically we do a percent and absolute reticulocyte count and compare it with other parameters like ESR, ferritin, serum iron and vitamin B12. And if the diagnosis is not made, then a bone marrow aspiration is done to make a diagnosis. Normally, the reticulocyte parameters which are done are absolute reticulocyte count and reticulocyte percentage. But Mindray hematology analyzers, the new Mindray hematology analyzers now give the LFR, MFR, and HFR, the high fluorescent ratio, middle fluorescent ratio, and low fluorescent ratio, as well as MRB and reticulocyte hemoglobin expression, which are the two new reticulocyte parameters which help in the diagnosis of anemia. So reticulocyte is increased during bleeding, any hemolytic anemias and hemolytic disease of the newborn, and decreased in iron deficiency anemia, pernicious anemia or folic acid deficiency, in aplastic anemia during radiation therapy and bone marrow failure. As we know, the immature reticulocytes have high RNA content, so the fluorescence is high. And as the reticulocytes mature, RNA becomes less and less and the fluorescence also decreases. So, depending on the stages of the reticulocyte, development of the reticulocyte, the high fluorescent ratio, middle fluorescent ratio, and low fluorescent ratio are provided by the Mindray hematology analyzer, and immature reticulocyte fraction is calculated by the sum total of high HFR and MFR. The patterns of IRF and retic counts are shown in this table. It shows that in aplastic anemias, in aplastic crisis, both the retic count and IRF are low. In hypoplastic anemias also, both are low. While in iron deficiency, we see that the retic count may be low or within normal limits, and immature reticulocyte fraction is high. In thalassemia, it may be within normal limits or it may be high. In folate deficiency, the reticulocyte count may be low or within normal limits, or it may be, and IRF is high. And in chronic diseases, the retic count may be low or within normal limits, but IRF is also within normal limits. What were our observations? Firstly, we studied iron deficiency anemia, which constitutes the major portion of all the anemias, that is 37% of all the anemias. Classically, how do we suspect iron deficiency anemia? When the hemoglobin is low, the MCD, MCH, MCHC is low, then we suspect that it is an iron deficiency anemia. How do we suspect iron deficiency anemia with the new parameters provided by Mindray hematology analyzer. It gives a hypo-RBC also, which should be less than 28 gram per deciliter, which is high in iron deficiency anemia. And the reticulocyte hemoglobin expression, which is normally 28 to 37 picogram, is low in iron deficiency anemia. So this are three cases of iron deficiency anemia in which iron, TRBC, and ferritin were low. It shows that the reticulocyte hemoglobin expression is low, 18.4%. The MCV, MCH, MCHC hemoglobin, everything is low. These are the three patients. One is male patient, other is female, 28 years old, male 46 years old, boy of 1 year, in which the reticulocyte hemoglobin expression is low. We compare the iron deficiency anemia parameters with other anemias like B12 and deficiency with chronic anemias and with thalassemia trait. And we saw that the red cell distribution width, the mean of the red cell distribution width is 21.5 in iron deficiency anemia, whereas in thalassemia it is 17.12. The reticulocyte hemoglobin expression is low in iron deficiency, 17.25 as compared to 20.22 in thalassemia trait. Similarly, in anemia of chronic disease, the reticulocyte hemoglobin expression was 23.425, which is quite significant. Similarly, in B12 deficiency, as compared to iron deficiency, the RHE was 24.85 as compared to IDA, in which it was 17.25. So this shows the RDWCV, which is high in iron deficiency anemia as compared to other anemias. The micro percentage is high in iron deficiency anemias. The RHE is high in anemia of chronic disease as compared to iron deficiency anemia, while MCHC is also high in anemia of chronic disease. Now we go on to anemia of chronic disease, which constitutes 27% of all the anemias. How do we suspect this type of anemia with the classic parameters? As we have seen that in 67% cases, the MCV may be normal. In 16.7% of anemia of chronic disease, the MCV may be low, and in 16.6%, the MCV may be high. So this is the algorithm for the differential diagnosis among iron deficiency anemia, anemia of chronic disease, and anemia of chronic disease with iron deficiency, according to Winter-Weiss review article in the New England Journal of Medicine in 2005. Whenever we suspect an anemia, we keep a biochemical or clinical evidence of inflammation, and we do a transferrin cyclation. If it is less than 16%, we have to rule out other causes of anemia. And if ferritin is less than 30 mg per ml, then iron deficiency anemia is there. If ferritin is between 30 to 100 mg per ml, then we have to do a soluble transferrin receptor. And if the STFR by log ferritin is more than 2, then anemia of chronic disease with true iron deficiency is present. If ferritin is more than 100 mg per ml, then anemia of chronic disease is diagnosed. So how do we suspect this type of anemia with the classic parameters? The retic count is normal, but the absolute retic count may be low or normal. And the immature reticulocyte fraction is high. With normal retic percent, it shows that the erythropoiesis is ineffective. Whenever we observe these parameters Then we have to study the blood smear and also correlate it with CRP, ferritin, transferrin, and other biochemical parameters. How do we suspect the presence of cells that appear in this type of anemia with the new parameters like reticulocyte hemoglobin expression? As we see that it is low in anemia of chronic disease, and the hypo RBCs are high in functional iron deficiency and anemia of chronic disease. So, these are a few cases of anemia of chronic disease in which CRP was high and the reticulocyte hemoglobin expression was low, 24.5%. The hemoglobin, hematocrit, and MCV, MCH were the lower side. These are three cases which have the same findings. So when we compared it with iron deficiency anemia and with high CRP, the anemia of chronic disease, we see that in iron deficiency anemia, the reticulocyte hemoglobin expression, the mean is 17.25, while in ACD it is 23.425. The microcytic count is 2.3% as compared to 0.8% in anemia of chronic disease. MCD, MCH, MCHC are higher as compared to iron deficiency anemia in anemia of chronic disease. This shows the comparison of RDW, microcyte percent, MCHC, and RHE in IDA and anemia of chronic disease. So the third case is a case of thalassemia with ineffective erythropoiesis. That is 12% cases with ineffective erythropoiesis. So we had some cases of thalassemia trait which we studied. In this type of anemia, the classic parameters like MCD may be normal or high, and in beta thalassemia trait, it is low. The RDW may be normal to moderate in other ineffective erythropoiesis, while it is high in beta thalassemia trait. The immature reticulocyte fraction is high, and the reticulocyte percent is high in beta thalassemia trait. While in MDS or B12 folate deficiency, the reticulocyte percent may be normal. These are few cases of thalassemia trait in which we see that the RHE is 19.1, the MCV, MCH, MCHC is low, and these are the cases. We compared it with all the RBC parameters as well as reticulocyte parameters between iron deficiency anemia and high HbA2, that is thalassemia trait, and we found that the RHE is higher in thalassemia trait as compared to iron deficiency anemia. The MCV, MCH, MCHC all are higher in thalassemia trait as compared to iron deficiency anemia. We had few cases of sickle cell trait in which we found that the RHE is low in sickle cell trait also, 22.6%, but MCD is normal. MCH, MCHC is on the lower side, hemoglobin is normal. So these are a few cases where the HbS was 19.2, shows a sickle cell trait, and RHE was 18.8, it was on the lower side. When we compared the thalassemia trait with sickle cell trait, we found that the microcyte percent was more in HbA2 as compared to sickle cell trait, and the reticulocyte percent was high in HbA2, high HbA2 as compared to sickle cell trait. This shows the RDWCD, microcyte percent, the Rhe and MCHC in sickle cell trait and iron deficiency anemia, beta thalassemia trait. So, in this study, our preliminary findings were that the reticulocyte hemoglobin expression provides an indirect measure of the functional iron available for new RBC production over the previous 3 to 4 days. The measurement of Rhe in peripheral blood samples is useful for diagnosis of iron deficiency in adults as well as in children. It provides an early measure of the response to iron therapy, increasing within 2 to 4 days of the initiation of IV therapy. Sequential measurements of Rhe in patients with iron deficiency anemia may provide a rapid means for assessing the erythropoietic response to iron replacement therapy. It is also an early indicator for iron-restricted erythropoiesis in patients receiving erythropoietin therapy, especially in cases of anemia of chronic disease. Thus, the reticulocyte hemoglobin content is a recent addition to an expanding list of biomarkers that can be used to differentiate iron deficiency from other causes of anemia, and it is provided by Mindray hematology analyzers without any additional cost to the patient. My sincere thanks to Dr. Ramon Simon Lopez for his immense help and guidance in this study. Thank you. This is our first basic findings in a few patients, but we are going to continue this study for at least 500 to 1000 patients so that we can reach to a conclusion and that we'll be able to present in our next few meetings, hopefully.
Thank you, everyone. Thank you, Dr. Ranjana, for such an informative talk. I don't see any questions right now. So is there any question? No, there's no question. So we thank everybody, whoever is online, and you can see the sessions online on this platform for a few days, 15 days, and then with the permission from speakers, the the talks will be displayed on Mindray India YouTube channel. YouTube. Thank you. Thank you so much.
Healthcare is often provided in busy clinical scenarios where lives are at stake. Decisions are made in a rush. Reports are analyzed on the go. Samples are tested in heavy volumes. How to reduce chaos and give caregivers more space to breathe. This is where we step in. We search for innovative solutions across clinical scenarios. By rebuilding connections between people, device, space, data, we provide a seamless workflow to ensure uninterrupted patient monitoring, dedicated devices and enhanced interoperability to support highest level patient safety and efficient management in the operating room. Integrated and intuitive information for quicker decision making, leading to optimal critical care. Smarter applications help you deliver a more confident diagnosis efficiently. And automatic laboratories perform effectively and accurately. professionals to work at ease, and hospitals to operate more efficiently, achieving optimum healthcare delivery. Together, we can evolve healthcare for